Okay. Good evening, all. Good evening. Welcome all. Welcome to members of the Health, Adult, Social Care Policy Accountability Committee to this evening's hybrid meeting. Welcome as well to those joining us online and also to officers, guest presenters and observers in the room, and a warm welcome to those that are viewing the live stream on YouTube. I am Councillor Natalia Perez, and I have the pleasure of chairing this meeting this evening. Before we begin, I have a few quick housekeeping notices for you. Please wait for me to prompt you before speaking. We have officers, external guests, and observers here this evening, both in person and online. When invited to speak, please introduce yourself and tell us who you are representing for the benefit of those viewing online. Please help yourself to refreshments. They're back in the kitchen area. If you need a comfort break, there are facilities located by the lifts. The nearest fire exits are also located near the lifts. We are not expecting there to be a fire alarm test this evening, so please respond if the alarm is activated. Before we move on to agenda item number 1, can I please invite members to agree a variation in the order of business items to take the minutes and actions last due to the number and importance of the agenda items? Is that okay? Great, thank you very much. Agenda item number 2, apologies for absence. And we have received apologies this evening from Councillor Patricia Quigley and also Roy Margolis. Agenda item number 3, declarations of interest. And I invite all colleagues to declare any interests, please. No interest? Okay, thank you very much. So we should have with us as well other members who are joining us online. Can I check the two that are online? Okay. For those colleagues who are online, are there any declarations of interest?
No. No.
Okay. Okay, great. Good to see you. I couldn't see the screen before. Excellent. Good evening. Thank you very much. So before we move on then to agenda item number 4, just to know that the public health update has been deferred to the January meeting, unless Dr. Lang, who is with us this evening and joining us remotely, has got any urgent items that she would like to raise.
None, Councillor Perez, thank you.
Okay, thank you very much. So the first item that we have for this evening is the Western Eye Hospital and Ophthalmology Services. This report from Imperial College Healthcare NHS Trust provides an update on Western Eye Hospital and Ophthalmology Services and the planned 9 million building project with additional operating capacity to help tackle the waiting list backlog created by the COVID-19 pandemic. The main report from Imperial College Healthcare NHS Trust is on page 11 of your reports. Please note as well that attached to the report is an appendix on page 17 of the PAC. Now, given this council's focus on co-production, this is distinct from the Imperial paper and intends to provide an independent resident perspective and patient voice. And this evening we have some contributors and guest speakers who I will introduce later. I also assume that everybody has read the papers. Therefore, I would like to please welcome Professor Tim Orchard to provide key highlights before we open up the floor for questions.
Thank you very much, Councillor Perez. Thank you for inviting us this evening. I guess there's probably best to consider this in 2 bits. The first is a little bit really about the Western Eye Hospital and what's happened to that, and then possibly a little bit more on ophthalmology more generally across the sector, which I'm partly responsible but not entirely responsible for. As you will see from the paper, the Western Eye Hospital has been about and around for a long time. It's settled in its current situation on Marylebone Road in the early 20th century. It is a building, I think that it's fair to say is not ideal in terms of delivering 21st century healthcare. As Brian Naylor notes in his paper, the plan has been to move the Western Eye Hospital when St Mary's Hospital was rebuilt into the big new redevelopment. I should say that I've been a consultant at St Mary's since 2003, and there's been a new hospital coming around the corner every year since then. So I think we have to accept the fact that we are lucky that we are in the 40 hospitals programme. We are hopeful that by the end of the year we will have more clarity over the 40 hospitals programme. But our view is that we can't rely on that at the moment as the answer to the problems that we're currently facing. The services at the Western Eye cover general ophthalmic services, but also quite specialist tertiary services. They, I think, do an amazingly good job given the physical circumstances in which they operate. If you look at the national register of outcomes, for example, for cataract surgery, the two centres in North West London, so at the Western Eye and at Central Middlesex, generally come out first and second in the country in terms of outcomes. And the results for the Western Eye are particularly impressive, I think, because they deal with a very substantially more complex caseload than most services. They also, which I think is quite an impressive feat, managed to clear the backlog that they had built up during COVID, with a lot of very specific work. However, last year we had some safety work done. As people who know the site will know, the Western Eye Hospital abuts onto Samaritan Hospital, the old Samaritan Hospital, which has been closed since 1997. We were concerned generally about that whole estate, and were thinking, what do we do about it? We got some independent experts in who told us essentially that we couldn't guarantee the fire safety in the Western Eye Hospital, and that meant a fairly precipitate move out of the everything on the first floor upwards in the Western Eye Hospital building. So that gave us some interesting challenges in terms of capacity. In the short term, we've moved most of the operating to the Riverside unit at Charing Cross. We do still have some services going on the ground floor and in the basement of the Western Eye Hospital. And we've built, those of you who've been to Charing Cross recently will have seen a sort of big lump outside the front. That is the new operating theatre that we are using to help us to get through the ophthalmic backlog. I'm pleased to say that as of July of this year, we've managed to restore all of the capacity that we had lost. So we're now doing the same amount of operating that we were doing previously. However, of course, we've got that gap between November and July that we need to make up. I think we're doing reasonably well, all things considered. So we don't have anybody waiting 2 years for treatment, and obviously there are, if you look around the country, there are people waiting 2 years for treatment. We have just over 100 people waiting a year, and we're hoping to get through those fairly quickly. Interestingly, the issue at the moment for us is actually not operating capacity. So I was talking to our clinical director this afternoon. Once we've got people into outpatients, the wait for a cataract operation is actually 2 or 3 weeks. What we need to try and do now is to increase the outpatient capacity to make sure that we can see people earlier. We obviously had the choice of, do we try and do something radical now, or do we try and sort out the Western Eye Hospital? My feeling, quite strongly, was I didn't want to get pushed into doing something we might then regret by rushing to something that sort of didn't actually, wasn't a good piece of work, essentially. So what we've done is we've managed to secure £9 million from the government's TIF funding, and I can never remember what it stands for. I think it's something like transformational infrastructure funding. It has to be, it's capital money that has to be directed at a particular project. And we were successful in getting that. And we have already started the work to make the site good. And we are going to not only replace the sort of get it back up to where we were, but we're also going to include an additional operating theatre. So we'll have 3 operating theatres rather than 2. We're going to refurbish the pre-assessment area and also refurbish our pre and post operative areas. So hopefully it will be a better experience for patients at the end. And we're hoping that will be completed by sort of mid to late spring of next year. So I think that's where we are with that. Is it worth me just going on and saying a little bit about how that then does fit with ophthalmology more generally, and then perhaps we can move to the second paper. So one of the key things, I think, so the West, if you look at the provision of ophthalmology services at the moment in Northwest London, it is very fragmented. You've got the Western Eye Hospital as the sort of tertiary centre for the sector, but we've also got services provided by Moorfields at Ealing and at Norfolk Park. And it's difficult to get sort of an overview. The other thing that is quite shocking when you look at it is that if you look at the rates of avoidable blindness by borough in Northwest London, there are really quite shocking differences between the best and the worst performing. So the boroughs actually be pleased to, in one sense, I guess, here, it's Brent, Harrow and Ealing have very significantly increased levels of avoidable blindness. And I think that, you know, as we come out of the pandemic, one of the absolute focuses now is about making sure that we really work hard to eliminate health inequalities and health inequities, and that has to be a focus. Clearly, for this particular group of patients, transport is always going to be an issue, and getting to move around is a particular issue. So we've had the lead clinicians working on how we can start to build a much more sensible ophthalmology strategy for the whole of the sector. And I think that will probably result in a sort of hub and spoke approach to this. And one of the things that I'm really keen to do, and this will require, of course, not just the acute providers, but also the commissioners, really to think about is how we can bring in the optometrists. So how can we use high street opticians, and how can we connect them digitally so that any diagnostics that are done can feed into the sort of secondary and tertiary ophthalmic services. And I think there is a degree of enthusiasm for doing that. And of course, one of the key things for us is to make sure that we then really understand the patient voice in that, and how we can get them actually to co-design the service with the clinicians that provide it. We're at the beginning of that pathway. There are all sorts of interesting contractual things to talk about. So there's what do we do with the service of Moorfields? How do we make sure that we get consistent standards from the Moorfields, doctors from everybody else? They're obviously an outstanding unit, but getting the visibility across the patch. And then there is the bit about how can we persuade the commissioners to support to get the right digital infrastructure and to pull it all together. And I think actually the discussions we've had so far, we've had one sort of approach to the acute programme board, which I chair for the sector, with a proposal to move forward. And I think we're very keen to do that and get that running for the next so that we've got something that will take us beyond the next 2 or 3 years.
Okay, thank you very much, Professor Orchard. It's good to hear as well that you have that big focus on co-design, which is something that we give a lot of importance to in Hammersmith and Fulham, and we want to enhance and develop as well. So it's fantastic as well to have here this evening with us other contributors, and it's great to have Brian Naylor with us, who is a resident and was actually a member of the PAC. And he has, some years ago, and he has come back for this agenda item, and he has produced a report representing the patient's voice as well. So welcome, Brian. Also, I think it's a good opportunity to please introduce the other guests. Thank you so much.
Thank you, Chair. I'm delighted to be here and very grateful for the opportunity of addressing the PAC. On my left is Stephen Sauerkopf, and Stephen is the Director of Services for the Macular Society, but he also plays a significant part in a newish organisation called the Eyes Have It, a partnership of a number of charities working in the visual impairment sector, plus the Royal College of Optometrists and the Association of Optometrics. So I would ask, if I may, for a moment of time in a little while for Stephen to be able to address the committee as well. On my right, we are very lucky to have another local resident, Andrew Hodson, and Andrew is the president of the National Federation of Blind People. So once again, and he is also a resident of Bocklington Lodge, which is in a borough, and has a fairly large population of blind and visually impaired people living there. So if I may, I'd just like to sort of cover quickly what Professor Orchard has said. First of all, I think it is true that nationally, there is a very, very large waiting list for ophthalmology services. And what is worse is that the caseload that is expected for that service is likely to increase on the figures that are available from RNIB, for example, by a minimum of 15% in what remains of this decade. But it is also true to say that there is quite a lot of research going on, and that research may lead to new treatments, which could significantly increase the numbers of, or the need for ophthalmic services. Now, it's quite clear that Western Eye Hospital doesn't just serve this borough, but the whole of Northwest London. And it's also clear, as Professor Orchard has already said, that it is no longer fit for purpose. And I am delighted to hear that there is some improvement there. But of course, it's putting a plaster on an old sore. And I think we need to hear from Professor Orchard and his colleagues what they intend to do to address the increased load that we know about and the increased load that may come along the track before we're much older. So, if I may, I would just like to very briefly say that we are in a situation where at the moment, the ICB is asking for improvements in terms of integration to primary care. And it seems to me that this is an opportunity for secondary and tertiary care to start making some very serious changes to avoid unnecessary workload. It was some years ago that I was told by the then chief executive of Western Eye that one of the reasons why the department was so badly overloaded, and particularly the A&E, was that a lot of people that were there didn't need to be, shouldn't be. And in fact, they were wasting valuable time for a very overstretched resource. And thus it is that in part of London about 10 years ago, where a trial was set up for a local hub for low-level eye care to be available using the services of both optometrists and chemists. Sorry. pharmacists, that's right, backed up by the professionals from the eye hospital. But the idea would be that a lot of the work of early diagnosis could be done in a hub close to the work, close to the locations of the people who are in need of that service. I was delighted to hear Professor Orchard say that they're going to look at producing hubs in some of the areas where already there is a considerable need for ophthalmology to have a presence. So that's one aspect. The second is that I think there are a lot of issues about pathways, and in particular, the pathway which is on the website of the Western Eye Hospital, requiring anybody who is referred to the hospital for treatment to be referred via their GP. Talking recently to a number of GPs, it is quite clear that they see no role for themselves at all in referral, and simply see the process of referral by GPs to be a delaying factor in an area which is critically already overloaded. And so it is, we ask Western Eye and Imperial, please to consider referrals by optometrists and other bodies, perhaps even the hubs that I've just been talking about. Finally, I think, because I'm conscious of the committee's time, finally, I think that we need to look at an organisation which is a bit different from that which the Fuller report suggests. The Fuller report talks about the four pillars of integrated care in the community, being doctors, dentists, ophthalmologists, and chemists. And that's fine, but it entirely negates the need for the social services, who also have a role to play in the whole of this, this process and this change, I hope, to the delivery service. So we need to have a system that engages with social services. We need to have a system that engages with carers. We need to have a system which engages with charities in the sector. But most of all, we need to have a system which engages with patients. And that seems to be remarkably absent from all the plans that we've seen at the moment, both at Western Eye and elsewhere. Although I will say thank you very much indeed, again, to Professor Orchard for suggesting that there is work going on in that direction. I could say a hell of a lot more over a very long period, but I think I'll leave it there for the moment. If I may have the indulgence of you, the Chair, if I may ask Stephen to add a few words to that.
Yes, of course. Thank you very much, Brian, and welcome, Stephen.
Thank you. Yes, and I guess so I'm Stephen Scowcroft, the Director of Services at the Macular Society. So I look after all of our information, support, education and training, our external activities, and part of that is helping to facilitate the voice of people affected by macular conditions and macular, age-related macular disease and other macular conditions are the leading cause of sight loss in the UK. And we kind of covered some of those aspects in terms of particularly the biggest pressure on outpatients, because what treatments are available for types of macular disease rely on people going regularly to hospital to have injections in the eye. That's for wet AMD. And as we said, there is developments and treatments that aren't currently in that category. So there's something like dry AMD where people don't have treatment at the moment, but the signs are looking good. The treatment and pipeline is happening, and in the next couple of years that will then increase the number of inpatient overnight potentially, and that will add to that pressure as well. So again, that's what we're looking at doing in terms of advocating for and raising the awareness of some of these challenges, and involved in some of those conversations around the country with the ICBs that are being set up, where we basically want kind of making them accountable for having eyes and the challenges and the plans around eyes as being, a priority for them as well. And it's really great to hear from what's happening in Hammersmith and Fulham with NHS and Imperial in terms of continuing to be innovative, because I think, as Professor Orchard mentioned, some of these were challenges before COVID, and there was a lot of national work happening with recovery and transformation and the national plans before COVID, because eyes were this greatest pressure. Obviously, that was exacerbated through COVID, but a lot of innovative and new ways of doing things were tried out and be more flexible around that going into COVID. And so again, now what can we do continuing with that? And some of those challenges are around workforce, but sometimes it's around not necessarily new workforce, but using the workforce that is available, with opticians, with other allied health professionals. So I think all of those are, it's really great to hear that those are being kind of looked at about the best use of that. And I think, again, from the kind of national perspective, certainly something that the Eyes Have It partnership are focusing on is having that kind of national plan, but with local that supports local delivery, but with that national accountability as well, because there are various frameworks and guidance, and actually that kind of gold standard of moving away from having the referrals through the GP, because that is a delay. It's seen as a kind of a barrier to opening up that, and looking at ways of doing that in other ways is a key part to that kind of providing that guidance and that beyond the kind of local way of doing that. And so therefore that's something that, again, us as the Macular Society are doing nationally, but Gwen, very happy to be supporting people who are affected by macular conditions, who are obviously key kind of advocates and have a voice within their local area, and to provide kind of that support to yourselves as a committee that's looking at that and has got that of interest as well. So thank you very much for the opportunity today, and hopefully this will be the start of many conversations.
Thank you very much for all your contributions. Brian, would you like to invite Andrew? Andrew, would you like to?
Yes, if I may just remind you, Andrew here is a local resident and of Pocklington Lodge, and therefore very involved with the local issue. Thank you.
Warm welcome to you, Andrew. Thank you very much for joining us this evening.
Hello. Thank you for inviting me to this meeting. I'm president, as well as being a local resident and chairman of the Pocklington Lodge Tenants Association. So my immediate neighbours have very much an interest in the facilities at Western Eye Hospital and improvement in the services. I'm also president of the National Federation of the Blind of the UK. We're a small campaigning charity, but one of our campaigns is called Support for Sight Loss. This focuses on rehabilitation and habilitation. But of course, that is very much connected in the pathway from diagnosis and treatment of sight loss. And the more these services can be improved, the less pressure there will be on the rehabilitation and habilitation services. But also, the more that the communication can be improved, the pathway between those services, the better outcomes for vision impaired people. So I'm very much in support of this campaign, The Eyes Have It, and I would like to see more improvements in what Imperial are doing and in what the council are doing to improve these services, because it will be of benefit to more and more people, because as we know, as Brian has said, population of visually impaired people is getting greater because of more people aging and living to the greater age and acquiring visual disabilities. So I hope that our presence here will have some influence on what you decide to do. Thank you very much.
Thank you very much, Andrew, for your contribution. I'd like to invite members of the PAC, please. And I know Victoria's hand has been raised for a few minutes now. So I would like to please invite Victoria.
Yeah, thank you, Chair, and thank you to all the contributors for your contributions. Yeah, I just want to mention a few things really. First of all, I want to thank the staff at the Western Eye Hospital for their service. I've received treatment there a number of times over the years, and I've always been impressed by the quality of the service I've received, their professionalism, their care, and their expertise. So please pass on my thanks to the staff. Two questions. First of all, the last time, when I first went to the A&E there at the Western Eye Hospital, it was a 24-hour A&E. The last time I went there, it was closed at night times. And I want to ask you whether they plan to make it 24 hours again. I would sort of strongly encourage you to make it 24 hours, because I think people will need that service at night time as well. Secondly, I want to raise some concerns about the quality of eye care at Charing Cross Hospital. I know somebody who recently had a horrible experience. He was attacked in the street. Somebody threw a chemical in his eyes. He wasn't aware of the Western Eye Hospital, so he went to his local A&E, Charing Cross, and they examined his eye very briefly, gave him some eye drops, sent him home. 12 hours later, he was still in a lot of pain, a lot of discomfort. So at that point, his girlfriend, who happened to know about the eye hospital because I'd mentioned to her at some point, she advised him to go to the Western Eye Hospital. And he went to the Western Eye Hospital, and the staff there told him that he really should be sent to them straight away by Charing Cross, because the treatment that they gave him was totally inadequate. And if he'd been seen by a better specialist sooner, his recovery would have been quicker, and the chance of him making a complete recovery would have been higher. So I just want to ask whether anything can be done to make sure that the staff at Charing Cross, if they're not specialists in eye treatment in A&E, that they are encouraged to refer people straight away to the Western Eye Hospital to get the treatment that people need.
Thank you very much, Victoria. Professor Orchard.
Would you like me to take
Yes.
answer each one in turn, or do you want me to take a number and then answer them all at the end, whichever you prefer?
Okay, let's have a few questions.
Thank you very much. I too would actually like to thank you all for your presentation, because I think it's been a very, very long time since we've actually had an item agenda on this actually very important area. So thank you very much for that. Could I ask you, why historically have referrals not been accepted from the hubs? Do they feel they don't have the expertise, or what might that be?
Thank you, Councillor Harris. Keith.
Yeah, thanks. I'd like to pick up a point Brian raised about the people presenting at A&E, and as the chief executive at Western said, well, they shouldn't really be here. I think part of the problem which we need to address here is the difficulty of people getting an appointment with the GP. So often they then go to A&E instead. So I'm just wondering how the trusts can liaise with the GPs to sort of ease this transition. If we've got a hub Then we've got the hubs. How will the patients know about these hubs? How will the information be disseminated? And finally, Brian said, working with charities. I think as an ex-teacher, we often picked up problems with children's eyesight at a very early age. So I think it's also important that education is done within the schools as well to give the teachers the tools to spot possible problems later. Thanks.
Thank you, Keith. Before we move on to next questions, would you like to address some of the comments and questions? Thank you.
I'll give it a go. And can I pick up some of the points that were made by, so lots there. Let me see. If I don't cover everything, please come back to me. So I want to start actually where I actually started previously, which is the problem with eye care in Northwest London is that it's fragmented. So the way that it has been commissioned has been that there's secondary care eye services and tertiary eye services, which are basically what we run. And then if you look across what the old CCGs commissioned, they then commissioned a series of community ophthalmology contracts, and the service for each borough in Northwest London was different. So what they commissioned was different, and so therefore whether or not you had a hub was different, or what the expectation was in terms of what to do if you're a patient. Now I have to say, I have quite a lot of sympathy with the argument that says most people understand in basic terms two bits of the health service. They understand their GP and they understand the hospital. And there is an interesting question for us about to what extent we try and maneuver people into new ways of accessing care, and to what extent we try and put the services in those locations. And that's, I think, fair to say, an ongoing discussion. And I think, to be honest, there's probably a bit of a middle way that we can reach. The opportunity, of course, with the ICS is that if you've got one group for the entirety of Northwest London, you should be able to get one specification for the community ophthalmic services. And of course, the sort of thing we're all aiming for here is then that actually links completely into your secondary and tertiary care pathway. So actually, you've got a unified system for the sector. And I think that is where we would really like to get to. And I think that if you talk to our ophthalmologists, that's where they would really like to get to as well. So I do have sympathy with people going to the A&E actually, because you know you can get treatment. You may have to wait, but you know you can get treatment. And if you're worried, I can see why people do it. But I do think it's not an optimal system, and we've got to try and do it a little bit better, I think. And part of that then goes to the question about, well, why weren't people taking referrals from the hubs? Of course, it's actually because the referral pathways are different from each part of the sector, and the traditional NHS referral pathway is from primary care to secondary care, and the way the contracts were put together, that was how it is. Now we've started the process of trying to break that down. So if you have wet macular degeneration referrals, then we've got a pathway where you can be referred urgently from either your GP or an optometrist. Now, clearly, the gold standard here is to try and get that across the whole thing. So there are 270 optometrist practices in Northwest London. What we would really like to see is that all 270 of those optometrist practices are the front door to ophthalmic services for our patients. That's quite a big ambition if you think about where we're starting, but I think it's where we would like to get to. And I said we're on the beginning of the journey. The model that people would like to deliver is one where you have a series of diagnostic hubs, where you have some treatment hubs, bearing in mind that some of them will be doing more complex stuff, and some of them will be doing what is in common parlance now called high volume, low complexity surgery. And we'll come on to talk about that actually in the next agenda item. So I think that those are really important things. What we have to do though is to really work as a sector to pull the community contracting into with the acute contracting to get a single answer. We'll then have to do not insignificant piece of negotiation with all of the optometrist practices. We'll then need to get everybody signed up to the same digital platform for diagnostics. But of course, the prize here is then an ophthalmologist can sit anywhere in the sector and look at the results and then make decisions. Of course, actually, you can potentially reduce the amount of traveling about the place quite considerably. So that in terms of the Western Eye Hospital, and so in terms of the refurbishment of the Western Eye Hospital, we as a matter of policy now at Imperial have the patient voice on all of our big strategic projects. So we do have patient input into how we're refashioning the Western Eye. The bit about the project I've talked about in terms of the strategy, we absolutely have to do the capacity and demand modelling that answers the questions that you put, which is what is the expected increase in the number of patients, and what is coming over the horizon in terms of new treatments. And what we've done in the short term is a very pragmatic, if you like, tactical approach, which was we've shoved in an extra operating theatre and we've created some extra space because we know we're going to have more people to treat. I think, and I'm very happy, Brian, if you would be interested in joining the work around the strategy for the sector, because I think we do need to have some very strong patient advocates. Final thing, thank you very much for your kind comments about the Western Eye staff, Victoria. I will pass those on. It would be really helpful if you can persuade the person who had that problem at Charing Cross to drop me a note. Because I think that everybody at Imperial has access to the Western Eye Hospital staff. And of course, we've got Western Eye Hospital staff at Charing Cross most days operating. I'm concerned to hear that people have not taken advantage of that. So it would be really helpful to know a bit more of the details so that I can then go back and pick that up. I'll take it back in general terms, but it's always quite helpful just to have a specific patient story. I think I've covered most things, but I'm happy to come back on anything that I've missed.
Thank you very much. It's definitely welcome. What you're suggesting in terms of having the patient's voice, and hopefully there is appetite from Brian and other colleagues to be part of that process and that working group to influence and impact the developments going forward. Thank you very much. I would now like to take a final round of questions or comments, please. I'm just conscious of time and we've got other agenda items to cover tonight. Yes, please, go ahead.
Tim, you've actually answered several things I was going to ask you, but I'd like to endorse one thing said by Keith Melanson just here about the importance of schooling. I worked in teaching, and quite frequently students were being held back a great deal because the school would recognize that sight was a problem, but didn't have the skills or the knowledge as to where to send people and to get responses quickly. So using the school's own health system, I think a lot of prevention work could be done there to the school nursing system and so forth, and pointing out to head teachers who have got their own forum where and how referrals happen. What I want to ask you though is about integration. There's a strange time now because there's an integrated care board and ICS, etc. But each of the trusts also works independently. And what you've given us is extremely interesting description of what Imperial is doing. What I'm curious about is how widely is the approach shared with the other trusts, because you're one of 4. And it's quite important, given inequalities across Northwest London, that the trusts actually work together. And that must surely be the case if you're trying to hammer out, which may take some time, new contract with optometrists. 2.25 million or 2.4 million people are probably covering so many optometrists are probably much easier to deal with from a central position where you can bargain and you can talk through contracts rather than just with one trust. And it does occur to me that there's an obvious question is how much autonomy do you have as either an ICS, ICB or the Joint Trust Board in agreeing different ways of working with different contracts and different obligations? Or do you have to wait for the NHSE to give you the thumbs up if you actually come up with something which is innovatory of the kind you're talking about?
So absolutely agree about schools. I think that that's one of the important things about pulling the community contracts properly into this and having and one of the confusing things is, you know, if you take children from multiple parts of Northwest London, the pathway would be different. So one of the key things we can do is to unify the pathway. As you will know, Jim, I'm now well outside my comfort zone as the chief executive of a large acute trust. So back in terms of the strategy, and I apologize if I haven't made this really clear. So that is a strategy that's being developed across the whole of Northwest London, so that it's being co-led by my clinical director at Western Eye Hospital and the clinical director at London Northwest, and the CRG, which is the group of clinicians from the whole of Northwest London. So I think, I mean, the answer to your question, I think, is if we come up with an innovative way of doing stuff, we don't need permission from NHSE to get on and do it. But what we do need to do, where I completely agree with you, it has to be done across the sector. We won't win. You know, we're a big organisation, but actually we won't win just by sort of trying to do it as a single organisation. It has to be the whole sector.
Okay, well, thank you very much all. I am very grateful for your contributions and the papers that you have produced for this agenda item. Thank you so much to Professor Orchard, to Andrew Hodgson as well from the National Foundation for the Blind UK, to Brian and to Stephen from the Macular Society. It's been great having you this evening. There's a lot of information, of course, and very important to note and to take into account in terms of future development. And I would definitely welcome having you again for a future meeting. And of course, conversation is always welcome, and suggestions and areas for development you may have also welcome.
Councillor Perez, can you hear me?
Yes, of course.
Yes, sorry, I might be wrong, but I don't think Professor Orchard answered my first question, which was, is there a plan to make the A&E service at the Western Eye Hospital 24 hours again?
You're absolutely right. I'm so sorry I did miss that. Yeah, that's certainly our aim in the medium term. I think we are just trying to work through obviously the issues that we have around the estate and small numbers of people being there in the middle of the night. So when we are back to our normal service, that would certainly be our aim.
When would that be roughly?
I think that we are hoping that the building work will be done mid to late spring 2023.
Thank you. Thank you.
Thank you very much. So in terms of future actions, I mean, we would definitely welcome regular progress updates, please, as to the implementation and delivery of the project. Also information on how the service is co-produced and incorporating the views of patients, and also the recommendations from other bodies, other organizations. Great, thank you very much. Okay. Okay, well, thank you very much. Can we please move to agenda item number 5, improving plan orthopedic inpatient surgery in Northwest London. We have also Professor Tim Orchard that's covering this point. So over to you, Professor Orchard.
I've got a feeling if I'm stuck now. I'm going to say, no, I'll sit here on the right. Feels a bit sort of dodgy. Yeah. Oh, that's fine. Yeah. I'm perfectly comfortable here. But perhaps it just shows that I have a slightly odd personality. I don't know. So we'll gloss over that and move on. Right. Thank you very much indeed for giving the opportunity about another actually really interesting thing. So I mentioned high volume, low complexity surgery actually when we were talking about ophthalmology. And I won't go into huge detail, but I know a number of people came to the consultation meeting earlier this afternoon. But it is probably just worth a little bit of background, and then I'm happy to answer questions, obviously. So there is increasing evidence that for procedures which fall into this sort of category of so-called high volume, low complexity, so not the most complicated surgery, but stuff that you do need to come into hospital to have done. If you can build a unit where you do the same thing repeatedly, you get a number of benefits. The first is you improve clinical outcomes, which is an important thing. So if you think about people who have hip replacements, you reduce the number of revisions that are required, so people don't need to have redo operations so frequently. You reduce length of stay and you increase throughput, so you can do more cases per day. And that largely is a result of the fact that the team gets very, very used to working together. They have a very, very well-organized procedure, and the patients are very carefully assessed before they come in to have surgery, and then are followed up in a very systematic way. And I mean, there are a number of specialties. So actually cataracts is another one where that approach can apply. Some of the urological procedures as well also fall into this sort of category. And one of the reasons that we have focused on orthopedics is because it is a large number of people. People are waiting some tens of weeks for surgery at the moment. And my personal concern, and people around this table will have heard me say this before, is that they're a group that it's quite easy to lose on the waiting list. So one of the things that we do when we are prioritizing waiting lists in the health service is to look at increasing levels of clinical harm. So that means if the condition is going to progress, then we obviously try and intervene. The issue with these conditions is that in a conventional sense, they don't progress. Not in that way, but the problem is they are incredibly life-limiting for people who have them. So it stops people getting up and out. That then has a knock-on effect on their normal lifestyle. That then has an effect on a whole range of other things: blood pressure, diabetes, mood, mental health, and actually, so what would be a relatively straightforward orthopedic problem then becomes a whole series of problems. So I think it is a really important group of patients to focus some time and attention on. So this proposal is to create a centre at the Central Middlesex Hospital that will do the high volume, low complexity orthopedic operations, which are basically hips and knees, with the most common things. There's a few, I guess, specific issues. So first question, I guess, is probably why the Central Middlesex. One really important thing is that it is not an acute site. So if you look at sites with an emergency department, the risk to elective care is that it gets knocked offline by what comes in through the emergency department, and that can be a real problem. By putting it on a non-acute site, you have a situation where you can basically guarantee that you've got, you know, a full day's operating every day. And that's probably the single most important thing. There are also issues about, we have done analyses of things like how easy is it to park your car, how is it to get there, and if you look in the totality of Northwest London, what does it mean for patient journey times? And if you do that, the sort of central mid comes out as a very sensible place to do this. I suppose there are a few key things to note. So this is out for public consultation at the moment, and I'm very, very keen to get as much public input during the consultation as possible. You know, I think we want to know whether people think it's a really good idea or a really terrible idea. I really hope people think it's a good idea, because I genuinely do. I think we really want to understand what people's concerns are. And we then want to sort of work with you and them to alleviate those. I think there are a few important things probably worth mentioning. The first is, it'll be the operation done at Central Middlesex. So the first part of the pathway and the follow-up parts of the pathway will still be done locally to where people are coming from. So you won't have to come up to outpatients at Central Middlesex and then go back to outpatients afterwards at Central Middlesex. That will be done in the local hospitals, which I think is important. The second thing, obviously, is there is an issue about transport, and I think that, you know, if I were a betting man, I would say that one of the things that is likely to come out of public consultation is concerns about transport. And I do think we will need to come up with an imaginative and sensible approach to making sure that patients can get to the Central Middlesex for the operation. I think that's really important. And then the final thing is that there will still be choice. So if you want to have an operation in your local hospital rather than at Central Middlesex, that will be possible. I think the issue, of course, will be that I don't think you will wait any longer than you are currently waiting, but you certainly won't get the quite speed of service that you would get by coming to Central Middlesex. But I think there will definitely still be that element of patient choice about where they have the operations done. I know you've had the paper, and many of you will have read the consultation document and been to the meeting, so probably sensible if I stop there and take questions.
Thank you very much. Okay, I've got Keith, I've got Councillor Worby as well, and Councillor Lord Harris as well, please. Yes, I'll come to you shortly. Thank you. Do you want to answer? Well, yeah, wants to ask this first question, please.
Yes, I've got a question on the patient journey, really. And I think the best way to do that is to illustrate it by two clients I've got. Initially presented to their GP with these back issues, then referred to MSK. MSK then attempts to diagnose via video. Now, this, quite frankly, doesn't work. Now, I checked with my friend who is a physio, and what he told me is, look, I need to see a patient in the flesh so that I can see the movements, I can look at the whole thing before I can do a diagnosis. But cut a long story short, there were these telephone consultations, which then proceeded to a visit, a face-to-face visit. In one case, the physio said, oh, no, we can't handle this. This really is a job for Charing Cross. So a patient is then referred to Charing Cross. Meanwhile, several months have gone by. The guy is in incredible pain. This has gone on now for over 2 years. Still no nearer a solution. Does he get an injection? He's had a couple of injections which don't work. Now they're talking about some surgical intervention. Similar case with another lady who was a client, and it doesn't seem that there's a seamless patient journey. I mean, you know, okay, it's all very well referring people on and between different parties, but these are people who are in pain daily because of their condition. How do we resolve that?
Do you want me to answer that, or do you want to?
So we're going to group some
Group it
questions
together,
and
but I
then we'll have another round of questions. Thank you.
Good evening, Professor Orchard. I've actually got 3 questions. Okay. Thank you so much for your reports. On page 1 of your report, the phrase completely separated from emergency care is used several times. So I understand that at the Central Middlesex Hub, you'll be seeing patients for planned orthopedic care. Presumably, if you have an accident that's life-threatening, you would be seen in A&E. But if you have an accident which is non-life-threatening and you need orthopedic surgery, where do you fit in? Okay. On page 3, you say that you want to make sure that you make the most of digital and other technological advances, which is absolutely fantastic. But technologically advanced equipment costs a lot more than more dated equipment. So how's that going to be funded? And on page 9, sorry, this is how interested in your report I was. It's complimentary. It refers to groups likely to incur longer travel times. Now, I'm not just concerned about additional travel times. I'm actually also concerned about additional travel costs. So how is that going to be overcome?
Thank you, Councillor Bobby. And a final question, please, from Councillor Lloyd Harris.
Thank you very much. Thank you very much, Professor Orchard. Just a couple of questions, and they've been touched on before and they were touched on earlier at the preceding meeting. But nonetheless, I think it's worthwhile asking again. That your report states there are about 4,000 cases in Northwest London that would sort of follow, that would possibly be able to use this particular facility. If we're working, and this is, are we going to be working potentially 7 days a week, 5 days a week? Because I'm wondering what happens when we get to the stage where the 4,000 have been addressed, because you're going to be able to do this because it's, you know, you have experts, they know what they're doing. So there's no downtime as such between surgeries. So when we get to that stage, what happens then? Do we potentially offer the capacity we have to other trusts, or do we look at something else? So that was, it was a little bit unsure as to how that would work. And just very quickly on the travel aspect, I think we all at the meeting beforehand queried that about how realistic it was, journey times. And as I said at the meeting, sort of going up Fulham Palace Road up to White City, some nights takes an hour. So I think, to be honest, that one needs to actually really look at these times, because some people are going to have to travel for quite a long time. It doesn't look like a big distance, but on public transport in this borough, getting to the hospital will take a lot longer than the 45 minutes or the 20 minutes by car. So if we could have a little bit more realistic information on that, and also obviously the costing and who's going to be paying for that. Okay, thank you very much.
Thank you. Sorry, Professor Orchard. Before I invite you for answers and comments, I would like to invite Councillor Coleman. I understand you've got a comment in relation to.
I was going to say something on what Keith said, but I'm very happy to let Tim answer first, and I come in if I have anything to add.
Okay,
Thank you.
let's do that then.
Right.
Professor Orchard.
Okie dokie. So I'm going to try not to appear evasive about the first questions, but so and interestingly, it comes back to an issue that we discussed with regard to ophthalmology. The pathways are fragmented. So I don't run the MSK pathways in any of the boroughs, and so there is a question about how effectively they are triaging patients and making sure they get into the right service at the right time. I do think one of the key things around the EOC is to make it fit in to a unified patient pathway, because I completely agree with you that at the moment, these pathways are too fragmented, and we don't want people sitting in bits of a pathway that aren't actually ever going to deliver the care that they need. I think back pain, I have to say, is a particularly difficult thing because there is so much back pain that is not amenable to straightforward treatment. I mean, and of course, what this set of procedures relates to is, of course, is pretty straightforward hips and knees and sort of straightforward orthopedics. So I think you're right. And again, I come back to, we know that across Northwest London, there are a number of community contracts, MSK being a key one. They, again, vary from borough to borough, and there is an opportunity to try and pull them back into a pathway where the secondary care element of it, does fit in a more seamless way. But I mean, I do agree with you that it isn't where it needs to be at the moment, and we need to work that out. I just, being absolutely honest with you, I don't think the EOC is going to answer the two particular cases that you flagged, but it is a good point. And we do need to work out as an ICS how we're going to deal with it. That's that one. Right, now there was very specific things. So this facility will be just for, as you said, just for people who have elective routine operations. Anybody else will need to do exactly what they do at the moment, which is to go to their local emergency department if it is serious, and they would do exactly what they do at the moment, which is to ring 111 and get sort of some triage advice from 111 if they think it's sort of immediate but not life-threatening. And they may suggest to go to the local emergency department. They may suggest going to an urgent care centre, but that's where those patients would end up. That's the first question, I think. The second one, I'm not entirely sure. I'm going to be slightly controversial. I'm not entirely sure that I agree with you, actually. And so actually, I think that in this situation, I think there will be no cost disadvantage to putting in the best digital solutions, because it will pay back in terms of improved efficiency. And actually, I mean, honestly, I don't think I would want to be part of something that was putting in sort of old-fashioned equipment that we knew was going to become obsolete. So I think I would say I don't think it will be a major cost problem. And of course, the other good thing is that this program is also being supported by the government's TIF funding. So we have got a big slug of capital in order to do it. So I agree with you. So we don't have the answer at the moment in terms of transport. I completely agree with both you and Councillor Lloyd Harris that there is more work to do to be really clear about what the actual travel consequences are for real people. And I do think, I don't think we're all sitting here thinking we're going to get away without paying for people to get to this centre. I think, absolutely there is going to have to be a solution here that makes sure that we are not disadvantaging people by moving the service. And then Councillor Lloyd Harris's question. Oh gosh, oh yes, so that's a really interesting question. So the 4,000 is actually the ongoing number. So generally speaking, we would expect to do that. I think, have we worked out exactly what the working model will be? I think the answer to that question is probably not quite. So there are probably two options for extending the hours. You can either do 3 session days, or you can do 6 or 7 day working. I think we will do at least 6 day working and probably 7 day working. I think that there's an interesting point. I guess if I were to get involved in this process again, I would probably separate out the model change, which is the movement of patients to a single centre, and the pathway change for those, from the capital build, of 2 operating theatres at the Central Middlesex, because that additional capacity, you're absolutely right. If we don't need it for orthopaedics, then there is ophthalmology, there is urology, there is ENT, and we would absolutely repurpose it to make sure that other aspects of surgical elective care where we can do high volume, low complexity work would be taken care of.
Before I invite other members of the PAC to ask questions, I understand that Councillor Coleman, you want to address.
Just if I may, just on something Keith said, actually, just if I may come back on something, it would be good to hear Tim saying about the possibility of the hospital or the orthopedic centre paying for people to come there. I mean, it would be the amount of money that's going to be saved overall. You know, if you used a private car firm to take the people there and send them back, but people who couldn't make it easily, I think that would be a good investment. We've already had this conversation to agree, you and I, but just to say the council would be absolutely behind you and probably pressing for this to happen. I'll let you come back on that. I just want to say something on the MSK, if I may.
So, yeah, I mean, you would not expect me to tell you what the answer was here and now, but I certainly think that is a very realistic possibility. I mean, I think that we will need to look carefully to make sure that we're content. Getting them in, I think it's relatively straightforward. Making sure when we take people home that we've got the right transport will be something, and as a gastroenterologist, I wouldn't pretend to know what the answer was. But you're right. I mean, I think it's a very sensible suggestion that we should consider.
Thank you. And just on MSK, I just wanted to come back on that, if I may, Chair. Keith, I couldn't agree with you more. There was during COVID, there was a reason why, if it could all be effective, the analysis or the meetings were taking place online, and people were being, the guesses, the physios were taking guesses about people and offering advice that way. I can see no reason at all why that should still be continuing. I'm surprised to hear that it is. So what we'll be doing, and I've been talking to Linda about this, what we'll be doing is we'll be writing to MSK from the council, and we'll be asking them to clarify what the situation now is, and we'll be setting out our expectations that people shouldn't be being, the word isn't analysed, what's the word I'm looking for, that you know, assessed, thank you very much, over a computer, over Zoom, but they should actually be able to do so in the flesh. So we'll take that up, and thank you for raising it.
Thank you, Councillor Coleman. Lisa, I see your hands up. Do you want to come in relation to what we've just discussed?
Well, one of the questions is, if that's okay. Can you hear me?
Yes, I can.
Okay. One of the, I suppose, just agreeing on the transport really, and Tim again, I think I've raised this before. It's just the issue of people getting to and from, both the patient but also people visiting as well. You know, and I know, gosh, I know that budgets are a problem, but you know, has it been thought about the transport, you know, laying on a bus, or, you know, I don't know, but I think these things are need to be thought about. That was one of them. The other bit that I was curious about was if all the expertise is going to be in a centre of excellence at the Middlesex, and you said that the surgery just takes place there, then and the sort of front end, presumably the diagnostic and the assessment, and then the follow-up is going to be carried out more locally. How are you going to ensure that you're going to have the relevant expertise of, you know, in terms of medical and nursing staff available locally if they're all in a central place? I was just not quite clear about that.
So I refer to where I started on the subject of transport, which, you know, if I were a betting man, transport will be one of the things that comes out of the consultation, and I am absolutely expecting that we will need to come up with, as I think I used innovative and imaginative what I used initially, but I think, you know, we are clearly going to have to make sure that people are not disadvantaged by a move of this nature, and you know, and it may well be that we choose to use a private transport company that you can call in real time. It may be that we have other solutions, but I think we've got to work out carefully where people are coming from and therefore what the right solution is. The answer to the second one actually is, I think, is reasonably straightforward. So we will continue to do a lot of orthopedics in other places. So this isn't all of orthopedics suddenly migrating to the Middlesex. If you think about it, there's only 2 operating theatres. So actually, if you think about it, on any day, there'll only be 2 orthopedic surgeons in this extra bit of thing, along with the orthopedics that's already being done there. So it's I suppose there'll be a maximum, I suppose, of 4 or 5 orthopedic surgeons, but there are probably 50, 60, 100, I don't know, orthopedic surgeons across the sector. So I'm not worried that we're suddenly going to denude everywhere else, because actually, firstly, they will be operating there, and secondly, there'll be regular clinics there. And I don't think we can promise that people will be operated on by the person they've seen in outpatients originally, but certainly there is that is a possibility. So I think it shouldn't be an issue, because we've got enough expertise.
Okay, thank you.
Thank you very much. Thank you to colleagues on my right. I appreciate your patience. I know I saw Lucia's hand. Okay. Would you like to ask a question, please?
Yes. Tim, transport's not going to go away, as it were. One of the things which is always reading the papers is that the new centre will help tackle backlog, but also this problem of orthopedics will continue into the future, no matter how skillfully the hub works. And by the way, I'm instinctively in favour of the hub. But in an earlier discussion, when we looked at the question of transport, it wasn't simply the cost of getting there and back, a private transport company, but it's a recognition that after surgery, many people are somewhat disabled, they're in pain, they're unable to proceed by themselves. And if it's a long-term project, which is likely to be the case as people become my age or even older, but is there a notion of developing perhaps a transport fleet of trained people who can not simply drop you outside your block of flats or house, but help you inside? And I'll say that because I have seen somebody having to pull themselves on their behind into a house and upstairs because the taxi driver, who was very obliging, had no training. And I think this is a long-term thing to think about, that the population is going to get older. But there's a second thing. I'm actually quite impressed by what will happen in the hub. But there is actually an ecology, which Keith mentioned, about MSK. Before you get there, you're likely to see MSK. And as part of HAPSON, except for the proposal to abolish Charing Cross Hospital, we've had more detailed complaints about the quality of MSK than any other service which is offered by the National Health Service. And I think it's quite important, if you're going to treat the patient holistically in an integrated way, it's what happens before with MSK and what happens afterwards when people go for rehab, for a variety of meetings with the physio. That needs to be seen in a far more holistic way. And I would appreciate thinking of that being incorporated into the final draft. Now, the final point, this came up in our group, but we've done some thinking about it. One of the challenges which is mentioned in the paper is dealing with people with conditions like disability, with dementia, and so forth. That these are groups of people who are getting larger in number. You will have access to the very good NHS stats about how this group is growing. It's about the training of staff to deal with this cohort of people, rather than simply the straightforward surgery on knees, on hips, and whatever. There are groups of people who do have surround questions, who will need more than, if you like, in the theatre skills, so that they actually come out of the visit to wherever the hub is eventually. It probably will be where you suggested, able to actually cope well.
So, right. Transport, yes. So transport is a very interesting question. And I mean, I think we need to remember, of course, so I mean, I made the point to Councillor Coleman. There is a difference between people being driven into the hospital and people being driven back from the hospital, because they'll be in a different physiological state. And I think that's absolutely right. And I think that, you know, at the moment, one would hope that, I'm sorry to hear about your acquaintance's issue. I mean, I think we would hope that the services to take people home would, you know, would actually cover that issue. I mean, the issue about a fleet of transport vehicles is something that we do periodically revisit. And I think, again, there are huge numbers of opportunities that come from having a more integrated approach across the sector. I suppose where I just have to be absolutely realistic is we've got to pick the things that we do in the order that we do them in. Otherwise, actually, we'll get nothing done, and then we'll all be sitting here being a bit cross about it. So I think that's an important thing. The bit about MSK and again, without wishing to be seen to have overly slopey shoulders here, I mean, we don't run MSK, never have, weren't involved in what it looked like, and indeed in the variability across the sector. I think for this particular set of pathways in and out of the EOC, it absolutely needs to be a properly integrated path. And if we don't take that opportunity, we will really have missed a trick. I think there is a separate issue around how do you commission the MSK services across, and how do the borough-based health partnerships take a view about what needs to go into their purview of MSK services. I think, you know, the ICS, I think, is working through what the sort of base offer is that looks across the whole of the sector, and how you then nuance that for individual boroughs. But I know I don't think anybody would sit here and think that we had got it entirely right with the MSK service as it's currently constituted. Final thing, I think it's a really interesting question. So I think that my suspicion is the way that we will end up running the EOC is that we will start with relatively stringent criteria for allowing people to use that facility, so that the thing gets up and running, and gradually over time we will increase the types of patient that can go through it. I think that for patients where we anticipate they would need a longer inpatient stay, so some of the groups that you described, I'm not sure that they will ever be really suitable to go through the EOC, and they may end up going through our normal channels. But I think they're really important questions. And I mean, I think the key is that whatever groups of patients we have going through, we do need to make sure that the staff on the ward are properly trained to deal with.
Thank you very much. I would like to invite Marilyn, please, as well. You've got a question.
Thanks, Meryl. So the team at London Northwest have obviously looked quite carefully at the issues around the PFI. So this is not going to be a PFI funded initiative, and we have gone into some detail about making sure that we understand what the consequences are, and making sure that how this development dovetails into the PFI doesn't cause us a problem. So I'm not anticipating that the fact that it's on a PFI site is going to have a negative impact from a financial perspective on the running of the hub. In terms of digital, I think you're absolutely right. And I guess, you know, it's a lesson to us all as we write this stuff, that it's very easy to put in about how, you know, how we're going to utilize digital to do everything. And of course, I think that is on the one hand very important. I do think, you know, we absolutely we should not be missing the opportunity to use all of the digital capability at our control. But you're absolutely right. I think it's incumbent on us at every point to explain that actually if digital is not appropriate, then there will be a non-digital analog, that's the word, an analog solution to the problem. And you know, in this case, I suspect an analog solution is likely to be a real person. So I think you're absolutely right to highlight that. And I think that, you know, one of the things that we are very aware of, and it comes back to the issue about health inequity, is we need to make sure that we are not disadvantaging any groups of patients by the way that we provide care. I completely agree. You know, I completely agree.
Okay, thank you very much. I'm conscious of time. I do want to ask a final question. So I went to the consultation this afternoon, and I want to know what steps are being taken as part of that consultation to reach out to maybe underrepresented communities. Have some communities been identified that you would want to be incorporated in that consultation? And yes, what systems do you have?
I mean, it's a really good question. So we've done quite a lot of work in trying to get this out to various community groups, the BME Forum in Northwest London, to any sort of community groups. As you know, I wrote to you and to all of the chairs of the Oversight and Scrutiny Committees across the sector to say, please, if you've got people that you think we should be connecting with, please do. And the results, the replies to those inquiries, we have tried to connect with those groups as well, and we've used all of the sort of the means that we have through various groups to try and access what you might call hard to reach groups. I think we would acknowledge that it's always almost impossible to reach everybody. But I think we have got to quite some lengths to try and get to as many groups as we possibly can. And as always, if you have any other suggestions of groups that we may have missed, we're very, very happy to engage with them directly.
Thank you. Councillor Coleman?
Tim, just on that, Tim, I was just thinking, it's funny because what we all hope is that and I mean, the ICS leaders very much hope that the 8 councils are going to be able now to come up with a single position, which we can just represent to them, and it's all going to be very easy, such as we expect that the ICS leaders are going to be able to represent a single position of all the different parts of the NHS to us councils. Equally, when you talk about something like the BME Forum across the whole of Northwest London, there's no way that's going to really, it pulls that many people in. We've got, and each council, it's a bit more boring, but I mean, you're good at this, Norma, as a very powerful rule, that each council has its own groups that will engage with the Faith Forum here, or the Building Trust work that we're doing, which you're aware of, and we have with Nubian Life and others. And I wonder whether it might not be more effective to approach each council and ask, and not say, can you distribute this to your people? Because when we put it out on Nextdoor, and we've done that, but actually ask the council if we can identify groups that you could write to. So you've got one for Brand. Is that what you did? You asked us to identify groups that you'd write to.
All the Oversight and Scrutiny Committee chairs in.
Well, Mazel Tov. I'm sorry, I didn't know that. So you've got all those names. Mick, well, what I can say then is that's very, Mick, well done. Can you share with me the groups you've got, and I'll see if we can add any names to that. Nice one, Tim.
Okay, brilliant. Well, thank you so much all. I'm conscious of time. It's 8:30. Thank you very much, Professor Orchard, for your time this evening. You've been with us 90 minutes, so it's appreciated. On a cool down, I think it's quite windy outside evening, so thank you. So before we move on to the next agenda, I would like to suggest that 5-minute comfort break, please. Yeah, 5 minutes. Please,
Allow us to have a guest as well.
yes, we also need to. Okay, well, thank you very much all. We've lost our coordinator, okay. Thank you very much. Can we please move on to agenda item number 6, West London NHS Trust update. And the next item has got 2 parts. The first part, that is the report that provides an update following the recent Care Quality Commissioning inspection of West London NHS Trust Community Mental Health Services for adults of working age and the actions on the way by the Trust to address areas of concern. And West London's NHS Trust current enhanced engagement activities. And then the second part is about the agenda item relating to the Ealing mental health beds. So we could please take the next part into those different sections. Thank you very much. And we've got with us Dr. Christopher Hilton. So thank you, and thank you for joining us this evening. Over to you.
Thank you very much, and thank you for the invitation to keep mental health on the agenda for the committee. I first of all wanted to speak to the first item very briefly, and then invite any questions about the information provided. So I won't speak to the whole report, but just to summarize that the trust was inspected for one of the domains of care that we provide earlier this year. That is community health services for adults. And in particular, they visited within Hammersmith and Fulham, one of the mental health integrated network teams. They and have rated the trust. So under 2.3 on the agenda, you can see that the trust's rating remains overall good, which is the same as it was previously. For the area inspected, we remain requires improvement overall, but it's important for us to acknowledge that some of the domains within the key lines of inquiry have fallen. Most concerningly, the safe domain fell from requires improvement to inadequate as a result of this inspection. And I've provided a table of the trust's overall position, which shows all of the different domains of care that we provide. And the bottom line is the most recent inspection, which is the inspection that we're talking about today. The committee will recall that I presented some information back at the start of this calendar year about the challenges that we'd faced. And it's important, I guess, to acknowledge that it's been an incredibly difficult and disruptive period for us, trying to emerge from the COVID pandemic and also to implement the new national specification for community mental health services. And around the time that we were presenting to the committee, we'd highlighted, and I think the committee asked questions about vacancy rates, waiting times, and the recovery of the services. And we'd agreed to continue to inform the committee of our progress against these. Around that time, I also added a risk from our level 2 register onto the trust's level 1 register. You can see within the report, there's a number of positive findings that were highlighted. I guess the most important of which for me was that the CQC confirmed that there was nothing particularly that they identified during their inspection of the services that the trust wasn't already aware of through our internal governance processes. And they did complement some of the work that had been going on in the early intervention services and with some of the aspirations of the MINT team, and found some positive feedback from the service users that they interviewed. But that's not to dismiss the areas of concern that they found. There were a number, and I've summarized them at 2.6 in the report. Related to the vacancy rates, this at the time this ranged, and apologies for a typo in the report, around 25%, and they felt that this made it difficult for us to provide consistent and a high quality service. They identified some challenges with the risk assessments that staff had recorded, and in particular, how we were mitigating the risks that had been identified in clinical assessments. They also found, as we had discussed in the previous committee, some of the waiting time targets were not being met, and there were a number of significant delays for patients accessing treatment. And there was a theme through the report around some of the decisions that had been made to use or to migrate from one electronic patient record system to another. And at the time of the inspection, staff were using 2 health record systems, which added complexity. There were some other findings related to lone working practice, and some of the clinical premises they felt were inadequate. And these were the premises that they visited in Ealing and Hounslow rather than at the Claybrook Centre in Hammersmith and Fulham. They also noted some of the supervision rates within the services were poor, with the potential for knock-on impacts. So I've shared in the report at item 2.7 a very high-level version of some of the actions that are underway to address some of these. And Chair, in our correspondence prior to the committee, you'd asked for a level of further granularity to the summary that I'd provided in this report. So with your permission, we've agreed that I would submit some additional information, which I believe has been circulated to the committee, and I'd be very happy to speak to with your permission. I think our colleagues from the technical team are going to share on the screen, and this will be made available to members of the committee on paper, I think, and I'm very happy to be added to all the minutes. Thank you very much. And if you could move on to the next slide, please. To give the committee some assurance of how we within West London Trust are monitoring the actions to address some of the concerns that were raised. They're tracked at multiple levels within the trust, and the key levels are at board level, following the escalation of the risk from the level 2 risk register to the trust's level 1 risk register, which is known as our board assurance framework register. There is a risk that is overseen by our quality committee. This was actually reviewed today at the quality committee with a range of indicators and data provided against some of the actions that we will come to. There is also a subcommittee of the quality committee called the CQC Working Group, and this oversees all of the should do and must do actions. And we also have a monthly transformation executive, which has yet a further layer of granularity of actions, both related to the BAF risk, the CQC risk, and the ongoing transformation work, recognizing that we're only still just over halfway through the transformation timetable. Shall I ask you to move on to the next slide, please? This is an extract, and apologies for the small print, those that have a copy will see it, of the Trust's risk register system. And it shows that the current rating of the risk, which is worded as the impact of the transformation towards the community mental health framework in our community and recovery mental health services, may cause risks to patient pathways and impact upon our responsiveness, safety, and the effectiveness of care, is rated as a 4x4 risk on a scale of 5x5 in terms of both the impact and the likelihood of occurrence of that risk, but with a number of mitigations to reduce that level. And you can see a number of the controls that are in place, including the executive meetings overseeing, which both clinical and operational directors attend, weekly reporting of the activity, and a review of the performance with a cycle of weekly meetings overseeing the recovery of the performance in the service. The business intelligence team has found a solution to integrate the data from the two electronic patient record systems. So compared with when the CQC visited the service, we have a much better understanding of the overall performance of the service drawn from those two parallel operating systems. And that is circulated on a weekly basis to a number of members of the management team. We've also been able to successfully implement a number of links between our two operating systems. There is now on the computer screen, there is now a link you can press that takes you from one system into the other without having to separately log in to get key information to support clinical care. The standard operating procedure for that's the next slide, please, for the services have been reviewed, and it has been agreed that we will establish a process by which the original concept within the development of the MINT teams between those patients that are more complex and require a secondary care level service, and those patients who are at primary care level, which was known as the case list, can be identified within the system. And the clinicians have worked on a proposal to flag those cases that require complex caseload management. To help you keep up to where I am, this is the second paragraph down on the right of the list related to the standard operating procedure. There's also a clinical task and finish group, which is looking at the actions that need to be taken for any patients that may not attend their appointments or who may be at risk of being lost to follow-up, to provide a more assertive response in the cases that are identified as needing more coordinated care. The final three actions on here relate to interface meetings between our community services and our acute mental health services to ensure that there is an agreement around the thresholds between when crisis services need to be involved and community routine services should be involved. And that's an action that was completed earlier this year. And as always, we continue to regularly monitor incidents, serious incidents, mortalities, and patient experience information related to the services. And that's both at team, service, and at trust level. And these are fed back down to clinical improvement groups at each team. Finally, work is underway to move from the really intolerable position of having two electronic patient record systems within the service to simplifying that. The reason we got into this process was that there was a desire to use System 1 as the electronic patient record shared by many of the community health services, and particularly with primary care. We've commissioned an organization external to the trust called Apira to develop both the business case and the implementation plan for the full migration of all of our community health services onto the dedicated and fit for purpose System 1 unit. So that gives you a summary of some of the actions that are underway in response to the BAF risk, the Board Assurance Framework risk. And I won't repeat those that have already been mentioned, but the subsequent slides in the PAC are from the CQC working group, and they explicitly address the should do and must do actions from the CQC. And most of them were identified by that committee as needing to be in place by March 23. So there is a current position recorded as at the end of Q2. The key actions related to staffing, and there is a series of actions across the trust already trying to improve our recruitment position, but there are also dedicated actions around recruitment for MINT specifically, which appear on a later slide and I will speak to. We are, in addition, on the next slide, the next one down, we've been asked to ensure that we have the risk systems in place to assess and manage patient risk. So there's been this alludes to a range of two things. One is the update of the standard operating procedures for the teams, and secondly, a range of audit activities to ensure that those changes have been adequately implemented and are being monitored. We're also monitoring, the feedback from this also links to the regular monitoring of governance data that comes from the team. The third item on this slide references the timeliness of access to services and alludes to that waiting time concern that the committee highlighted earlier in the year. And I guess there are two actions underway to address this. One is improving the reliability of our reports, making sure that we are clear which patients have been waiting for how long, and making sure that we've got visibility of those patients who need more urgent intervention. And we've also increased through that BI reporting the option to, well, the ability to identify individuals who are at risk of being lost to follow up. I'll quickly finish these because I know this will be stimulating a lot of questions. The subsequent actions on the next page relate to loan working policy, and there's been a comprehensive piece of work reviewing, standardizing and circulating and educating our staff about loan working procedures. The supervision reporting has been reinforced and time allowed for staff to do that, and there are quality improvement groups in quality improvement projects in a number of different teams which seeking to improve the overall rates of supervision. Finally, the electronic patient record action is recorded here again, and I've already alluded to some of the work that's underway to address that. And then finally, on the next slide, please, there was an action to improve mandatory training. The Trust has an ambitious target to ensure that all of our staff get regular training across a range of domains, and there's been substantial improvement in the training received by our staff since the CQC visited. Partly that's related to the reintroduction of a number of face-to-face courses that had been suspended during COVID, and we're now working through staff improving their compliance with them. I guess finally, and I won't go through the details on this slide, but it's just to show you a range of the both drivers and actions that are underway to try and address recruitment. Some of them are external, related to attracting people to work in the organization, and we've had some trust-wide successes here, with the Trust actually having the highest staff survey results of all NHS organizations in Northwest London, so making that known that we are a good place to work. But also trying to move some of our temporary staff from temporary assignments onto the books, and making it more attractive for them to do that. And a range of other activities that you can see here, and I'd be happy to try to speak to. I guess finally, the last couple of slides in this pack were really to illustrate some of the work that we've been doing jointly with the local authority and voluntary sector through the place-based partnership. And this is particularly aimed at trying to identify partners to help us with some of the demand that we are experiencing within the mental health services, but also working with groups that may provide more culturally appropriate care for some of our service users. And Helen, I don't know if you wanted to add anything particular about these couple of slides as well.
Just to emphasise, it's a great bit of partnership working with Joe and Joe's team, a partnership with West London and the Borough, and Sobus in particular, just to commission a range of organisations, and they were commissioned earlier on this year. So we have 16 organisations in place across the borough, spread across the borough, ranging from grassroots to bigger organisations. Probably the biggest is the National Autistic Society. And the aim is to reach different groups that our services tend not to reach. They are given quite small amounts of money, but they are doing really innovative stuff. And so an example I think is given in the slides of the listening place that's based in, I in Shepherd's Bush, and that is really focusing on marginalised migrant groups who experience suicidal thoughts. They've seen, so I think 65% of referrals are coming from BAME communities. That is a new organisation. It's really exciting to see. The Autism and Mental Health Project, the Minaret Centre, has seen 70 or is seeing 70 individuals a month. They're not using that much money, but it's very exciting. It's very early in its development. Our aims in the next stage are to try and pull out the activity in much more detail so we can really talk to the detail. And actually, I want to say real thanks to Joe's team, because the actual burden of, say, contract management has been quite enormous. And I don't think your team are quite expecting the burden. And I think the interesting thing about the initiative is the organisations. We need to support the organisations to build capacity. So I think it's year one. We've just extended the contract to October of next year. And we're also going to actually try and put a bid in for, there's some monies available for population health to take forward a lead provider model in the new year. So that's a really useful piece of work that we're doing at the moment, and really supporting the front end of our mental health services. So a lot of work is going on also to connect those services to Mint and to GP practice.
Thank you. Just one final paragraph, if I may, before returning to the chair, was just to acknowledge back to the original report, and I think the slides could come down. I've tried to include a few facts and figures to help illustrate some of the work that we've been doing, and you can see that the vacancy rate across Hammersmith and Fulham remains 26%. That is lower than some of the other areas in within my portfolio in other boroughs, but there's still obviously a lot of work to do. I've also highlighted the patterns of referral activity, and we did see an increase in referral activity following the pandemic, and this has now started to come down and stabilize, which is going to be helpful for us in reaching a steady state position. And I've also highlighted some of the supervision rates. The headline figure is an improvement at about 40%. But what I can say is that some of the teams within Hammersmith and Fulham, where they've been doing the focused QI work, are now up to 100%. And we're seeking to maintain that, and we'll be happy to share with you the ongoing data. And you can also see the mandatory training figures of the 24 courses that we ask our staff to do. I think there's only one course which has got less than 2/3 compliance, and 17 are up at 80–90%. And that one course is one of the face-to-face ones that's been reintroduced. So I wanted to thank you for inviting us, and also to offer to continue to provide this data to the committee as we continue to work our way through these actions.
Thank you, Christopher, and thank you, Helen, for the written report and also the additional information submitted today. I would now like to invite members of the PAC to ask questions. We've got Councillor Robin, and we also have Keith Mellison, and we also have Jean, please, and then Chair. Councillor Robin, please.
Good evening, Dr. Hilton, and good evening, Helen. Thank you for your reports. Okay, in short, I've actually got 4 questions. So I just want to go to my first point. Okay, so my questions are actually about staffing, because I'm quite concerned about staffing. Of course, I understand that some of your action will be long-term as per the long-term plan. But my first question is actually, what immediate action are you taking following the CQC report and its findings? On page 5, all my questions allude to paragraph 2.6, by the way. On page 5, it talks about the risk assessment for some patients were brief and did not always explain how a risk was mitigated or followed up in a timely manner. Obviously there's the risk to the patient, there's also risk to other patients, and actually to staff. And it goes on to say that staff did not follow safety protocols for lone working. So my second question is, how are you going to be able to ensure staff are not put at risk going forward? So the first question is about immediate. My other 3 questions about going forward. So the first one's about how you're going to ensure staff are not put at risk. On paragraph 2.6 still, but on page 6, it then goes on to say supervision rates were poor with the potential for staff to feel unsupported as a result. So my third question is, how are you going to monitor the performance of staff and actually the management of staff? And the final question really is an aside, and that's would be quite cheeky. I just wondered if you've actually suffered any legal consequences, because I'm no lawyer, but it would appear that the Health and Safety at Work Act 1974 has been breached in this case. So that's my 4 questions.
Thank you. Councillor Ruby,
Thank you. Hi. First of all, I'd like to look at 2.5 positive findings, and it's just a comment on it, that the final rating for community-based mental health services for adults of working age. Now, I've spoken with Chris and Helen separately from my organization and with Joe, and you know, I'm happy to say that I think this is now acknowledged and things are going to improve. And I'd like to put it on record to thank Chris and Helen and Joe for the fantastic support they've given to my organization. Without their input, I think I'd still be going around in circles. So if that could be recorded, I'd appreciate it.
Thanks to Chris and Helen for this, particularly for the additional information, which has got rid of a number of questions I wanted to ask. Looking at the additional information, however, much of it is predicated on staff. I think that needs to be acknowledged. I'm going to ask a speculative question, and I'm going to ask subsections within that about the actual state of affairs. You've got quite a lot of stuff about how you will try to recruit new staff, but realistically, how likely is it that you will actually recruit many of the staff which you're actively setting out to bring on board? And I say that because I know nationally there's something of a shrinking staff pool. So you're in a market against other trusts up and down the country who are also doing, trying to do something similar. And then I was going to ask is, with the shortage of staff, vacancy rate of 26%, 1 in 4 is pretty high in any job. What realistically, Chris and Helen, what effect has this had on patient safety? What are the implications for continuity of care for patients, particularly in a field where continuity of care must be far more important than many other parts of the health service, in that people have repeated crises and need to come back to be seen multiple times and not to have to re-establish personal relations with somebody. There's a figure there where you say the waiting time is 64 days, which is above the target you've got, but you actually don't say what the target is. So whether it's 20 days out or 1 day out, that's significant, if you like, in time scale of a difference. And because people's condition may well deteriorate quite a lot if they got to wait to be seen for a long period of time, rather than being seen a day or two after the expected. And I would like to see a breakdown in terms of the waiting list, in terms of ethnicity, social class, poverty, And I say that because the national figures about mental health are not, it's rather like this weather. It's very threatening, simply because there's growing poverty, there's growing uncertainty and so forth. And just as this COVID did set you back immensely, a new poverty cycle may well put additional strains, which are very hard to meet. So it's a question of vacancy rate and its effect on your actual everyday going on work, because what you said in partnership and so forth and comes later is very ambitious, but it can't carry through unless you've got people to work the jobs which you've set yourself. Yeah.
Thank you, Jane. I would like to give that as well.
Hello, hi. Mine was basically a continuation of what Jim was saying, and you know, and I was just looking at your figures of you're now down to 3,000 thereabouts. But again, you know, with the current economic climate, obviously that will impact on mental health, and you know, just from you know, local experience and local knowledge, I know that on the ground there are still really long delays, having face-to-face family therapy, etc. And surely this is all an impact of the shortage of staff as well. So it's just sort of a continuation of what everyone else is asking.
Thank you, Lucia. So you've got some questions there, Dr. Hilton, from Professor Bobby, from Jim, and from Lucia.
I'll do my best to try and work through them, but as Professor Orchard did earlier on, if I fail to answer them, please do call me out. So I think there were 2 or 3 that related specifically to staffing. And one was what immediate actions were being taken. Some of the data that's been quoted reflects the fill rate of permanent NHS staff on our books. That doesn't reflect the use of agency and temporary staff that we also engage. So the headline figures that are quoted exclude some of the additional clinical staff that we've sourced to help undertake some of the work. So one of the immediate actions is also trying to fill up the temporary vacancies with temporary staff to make sure that we can continue to do the work. There have been a number of other initiatives that the service line has been leading on. And one of them is working very closely with local universities to try and identify potential workforce at source. And I'm pleased to say that this has had quite considerable success, bringing into the multidisciplinary team a new role of a graduate mental health worker. So a number of these are graduate workers who have an interest in mental health and often a desire to progress either to a nursing degree or to a psychology degree. And we've recruited, in conjunction with local universities, many dozen of these staff. I'll get you the exact number for the committee afterwards. And these roles, it's important to say, are not nurses. And we recognize that, and we're not trying to replace the absolutely central role of nursing staff within our teams, but they are adding to the multidisciplinary workforce to support some aspects of the patient's continuity of care and work. A number of other actions underway, some of them were listed in the PAC on the driver diagram around trying to get our temp to perm arrangements, getting people onto the books, trying to make the attractiveness of the organization more attractive to attract people in to work in this area. So there are a number of immediate actions underway. Jim asked the question about realism in here, and it is recognized that this is a challenging job market, particularly for qualified nursing staff and for some of the allied health professional disciplines. We're doing so to answer your question directly, we are realistic, and I think we recognize that some of these challenges are not going to be entirely eliminated. But we're doing work both directly ourselves, and I highlighted the Trust's positive staff survey result as one example of trying to demonstrate why coming to work for West London Trusts, in Hammersmith in particular, would be a good choice for individuals in the NHS job market. We've also been doing some focused work as an organisation with refugees who might have clinical skills to come and join the organisation with some success. And we've also been doing some targeted international recruitment with some success, with appropriate ethical considerations around that. Just to I'll come back to some of the other questions that were asked earlier on, but since I'm on a roll with Jim's question, your question about what has the impact been on safety, and I think the answer is there has been an impact on safety due to some of the challenges. It's slightly hard for me coming in halfway through the transformation into my new role, and the transformation being complicated by COVID, to unpick some of the root causes of it all. But I think it would be wrong not to acknowledge that the CQC has found inadequacy in some of these areas. And if you read the full report, it highlights risks to continuity of care in particular as a challenge, as a resulting from that. I'll come back to some of the health and safety question. What actions are we taking around risk? In the report, I've highlighted some of the work we're doing with staff and some of our processes and protocols and systems to encourage an improved risk formulation approach by our staff. So not using black and white tools around high risk, low risk, which are now no longer advocated by NICE, but understanding the factors that contribute to risk and how these can be mitigated. And in terms of staff risk, one of the things that we have found when we're going around the teams is that there is an understanding of staff needing to protect themselves when working as lone workers in the community. But I think the CQC were particularly concerned that there was a lack of consistency of the staff members' understanding of those processes. So the work that the teams have done in a targeted way is to, and in fact, we went around and used a validated tool to understand the risk climate within our teams to try and help staff better to understand the importance of this, and putting in audit and sort of dummy run processes to some of our lone working procedures to test them. To answer your question about the league, I'm not a legal expert either, and I'm not aware of us having had any specific health and safety related claims to this. But of course, we're aware of our obligations in this area, and that's why it's so important to us to resolve it. And in terms of supervision, we monitor as a trust supervision at team level, at service level, and at trust level, and we report and are working with teams to do this. The QI approach that they're doing, trying to get staff members to understand the importance of supervision, both managerial and clinical/professional, has seen benefits. What I'm keen to do is make sure that they're sustained, because I don't want 100% in September and then back down to 20% the following month. What else have I missed? I thank you, Keith, for the comment that you made. I do want to also acknowledge, though, that I'm pleased to be able to help you, but as we said before the meeting over coffee, it shouldn't be the case that you need to contact the executive director to get the answer to some of your questions. So I think that's the work that we're doing internally to try and simplify that process for you. Weights the mean wait is 64 days across the 3 Mint teams in Hammersmith and Fulham. We've now got a clear understanding that there is a triage, and I was visiting the Claybrook Centre just before we came here, and there are no patients waiting for triage for Hammersmith and Fulham Central, which is an improvement on what it was earlier in the year. Post triage, we now have an understanding of those patients who need to be seen in what we used to call routine plus. So that was within 7 days, and those patients who are routine. And so there is processes in place to assure ourselves that patients who need to be seen in the routine plus zone are having an assessment from a clinician in that time period. And the impact then is on the longer delays for some of the routine work, which I think is what committee members were describing. I hope that's covered most of the points.
Thank you for covering these points and questions. I would now like to invite Lisa, please. I can see your hand has been raised.
Yeah, thanks very much. Can you hear me okay? Okay, so thanks Christopher and Helen for coming, and also for going through that. That's really helpful. And you know, mental health is you know, we've got enormous problems in terms of the high rate of mental health, severe and enduring mental health in this borough. So you know, we've got our work cut out. So I think we all need to acknowledge that. Plus a very high suicide rate. And also, as you've gone into, you know, huge staffing problems across the NHS. One of the things, couple of questions for me, supplementary questions really. Thanks for sharing the action plan today. Just in terms of the detail, so can I be clear, who heads up the performance improvement plan in the trust? You know, this plan, who chairs? I'm presuming there are performance improvement meetings. Who chairs those?
So there are 3 levels of meetings. The quality committee is chaired by one of our non-exec directors, Professor Barber, which oversees the BAF risk, of which I'm the executive sponsor. The Mint specific executive board, which is overseeing the more granular action plan, is chaired by me on a monthly basis. And there are individual working groups chaired by the clinical director, Dr. Julia Renton, every week. Right.
Okay. So and pace wise, do you, in terms of progress, do you judge that you're making sufficient progress against the required improvement areas, and particularly all the required improvement areas and the inadequate area? And
So just to answer your question, Lisa, my take on that is I think we're making satisfactory progress on most of the areas. So following the diagnosis of and the plan development, I think we have made progress around some of the staffing plans, some of the mitigations, and some of the protocol work that I've described. I'll share with you one personal frustration, which I think is not making satisfactory progress, and that is the resolution of the 2 electronic patient record systems. And I'm keen that we get the independent consultancy report in the next few weeks that will move us from the current mitigated risk position to a much more definitive solution.
Yeah, and how far are staff involved in the performance improvement? I call it performance improvement, but how far are your sort of ground staff on the ground, basic grade staff involved in the improvement plan?
So I think, as you'd expect with these things, there's a cascade of membership and then subgroups working on this. So that the meeting that I chair is attended by the clinical director, the operational managers, and the clinical leads, including the service manager for Hammersmith and Fulham and the clinical lead for Hammersmith and Fulham. They then take away the actions at their local meetings, and it should go entirely down to the community version of ward level for that work.
Okay. And finally, on the sort of technical bits on the plan, you know, you talked about supervision, and I don't sit on high. You know, I know how important it is to get the basics right, but the supervision rate is worrying really. And are you auditing supervision at the moment? Are you auditing rates of supervision, and is that part of somebody's performance monitoring, for example?
Yes, it is as described. So we look at on a regular basis at team level and at the recovery meetings that we've described, and at the routine performance meetings that I have for the division, the supervision rates across the service lines, and there is wide disparity between some areas. So, for instance, our older persons mental health services, which is not what we're talking about today, have extremely high rates of supervision consistently for month on month on month, and the community adult health services have, for a long period of time, had poorer rates of supervision. There are likely to be two elements to this. One is a culture of participating in supervision, receiving supervision, and giving supervision. And the second thing is recording it. And we're trying to improve both the culture of doing it, and secondly, recording it so that the organization is assured.
Okay.
Third piece of work is also looking at the quality of it.
Yes. So big project and big problem. And then I suppose my last bit, which is segues into the next item when we talk about the loss of the 13 healing beds. The worrying bit, and it must be worrying for you as well, is that you know, if the trust's trying to reduce its bed base and the strength of the community services are questionable, how do those two bits correlate? Really, you know, that's the worry for me as a social care director, really, in the area. That's the worry, that actually the community health services have to be tip top to be able to cope with the level of people who are looked after in the community, and you know, it's to state the obvious, like yourselves, it's very worrying. And I don't sit on high with CQC inspection, because, you know, we're all inspected, and you know, there's always huge improvements to be made. But I think this is a really important service to get right, given the focus on community care and the focus on community care over the last 20-25 years. And I totally acknowledge lack of investment in community mental health services and all the rest of it. I completely understand that, but it is worrying.
Just to respond, Lisa, I share your concern, and I also share your perspective about the interdependencies between different bits of the system, so the resilience of the community services and the access to acute and crisis services. We do recognise that inside the trust, and I don't know if Helen wanted to say anything about work that we're doing on which I know you and colleagues have been involved in, looking at flow through our pathways and understanding the interdependency between community and hospital, and then hospital back to community. Was there anything you wanted to add on that, Helen?
Just that we've started a programme of flow. So we've been working with a consultancy, RW Health, a clinically focused and business intelligent consultancy, and they have been examining our patient flows in a way that we haven't seen before, and they presented back to us our data across patient flows in a very interesting way. That's led us to the engagement work we've recently done, which is going to lead to a series of task and finish groups. They've done some really quite interesting work in, for one example, producing a useful dashboard. It kind of goes to your point, Jim, about continuity around people who are at high risk, and in particular those who maybe come into hospital more than once in a given year. So we have got a methodology, if you like, to actually identify that group to work and focus on, and we're doing some focus work on that at the moment, so it's probably worth saying that. And some of that focus work is actually knowing who those individuals are. So, for example, there's 40 of those individuals right now in Hammersmith and Fulham that we actually can do some. So we're actually going to do a focused piece of work around contacting them and asking them what their experience has been in the last year, and what can we practically do to improve their experience over the next year. So that's a small bit of work, but I mean, the more important thing about the dashboard is the question we're asking of our different teams, including MINT, crisis, inpatient, liaison psychiatry, who holds this dashboard? Because it's available for people to look at every week, so that we can actually identify name individuals that we can focus on in a different way. So it's a different way of like approaching continuity and risk. So that's certainly one area that we're just embarking on at the moment. The other thing that piece of work that RW Health have done is actually done a bit of a diagnostic around the front end MINT pathway. And they've got a number of very interesting suggestions, which we're just looking at the moment, about how they might make themselves more efficient. For example, they're spending a lot of time in triage meetings, which are good because they've cleared their triage wait, but there's probably other ways of maybe using their resources. So I think, again, that will be another piece of work we'll take forward over the winter. And we do think it should improve and get to our more optimum position in terms of the community mental health service, which kind of goes to your point, Lisa.
And one just quick follow-up is it's worth recalling that the original plan for the mental health transformation was not a quick transformation. It was expected to take a number of years. So I think we are seeing some of these ongoing actions as both remedial for the CQC findings, but also ongoing as part of that planned transformation work.
Thanks very much. Thank you.
Thank you, Lisa, and thank you, Christopher and Helen, for answering those questions. Colleagues, I'm conscious of time, so I'm going to invite the last round of questions, because we still have got to cover the West London Trust Mental Health bed capacity. Then we have the minutes and the work program. Thank you very much. So I've got Meryl, I've got Councillor Lloyd Harris, and then I've got Linda Jackson, and then Councillor Coleman.
I did. I'll be quick. I was told I had to sit over here. The first thing is, I mean, thanks for the papers. The supplementary paper, which my eyes can't cope with the size of the print, but I think one comment is, and I realize you've done this very quickly, but there's an awful lot of technical jargon and acronyms in it, which trying to read now makes it very, very difficult. Please, can we have it more explanatory? I just want to draw attention to two graphs which are on page 37 on mine. I think it's in 2.7. One is, they're about MINT. I think one is about new referrals, and I think it's interesting to see that new referrals seem to be falling off, but there is no explanation for that. You may not want to comment now, but I think to present a graph with no explanation for that isn't necessarily helpful. But even more interesting, and I think you may not be able to give it now, but I think it's something that for the borough is something we should be concerned about. If you look at the new referrals via PCNs, there are huge differences between the new referrals per PCN. And from my knowledge of the different PCNs, they don't particularly seem to me to relate to the populations that those PCNs deal with and what one might expect in terms of referrals. You may not be able to answer it now, but I think that there is a need for some sort of explanation for those differences, because it may be indicating that there are some people who are not being reached.
Meryl, Councillor Lloyd Harris, please.
Thank you very much. I don't mind who answers this one, but Lisa, you mentioned that the suicide rate was high. Now, could somebody tell me what, in comparison to whom? And if that's accurate, can somebody please elaborate on what preventative action, if any, can be taken to address this?
Do you want me to answer that, Councillor Lloyd Harris, or make a start?
I'm very open to either one of you doing it.
Okay, I'm happy to make a start. So So we've got the facts and figures on the suicide rate, and in fact, Dr. Nikki Lang has headed up over the last year, which was initiated by the leader of the council, a suicide task and finish group in the borough, which is a multidisciplinary group, and she's done quite a bit of work on that. So we can certainly explain the comparison, why we're high, and we are I think typical of so some general facts, typical of an inner London borough in terms of the people who live in the borough in central London, and its attractiveness to people with severe and enduring mental health issues, i.e. gravitating often towards central London. We have a high number of substance users as well, and we have found that, and Nikki, feel free to come in, we have found that a lot of people sadly who take their life have either a dual diagnosis, mental health issue, and a substance misuse issue. That the prevalence is quite high. Nikki, are there any other sort of quick facts that I have missed, really general facts?
Yes, and just to say, the suicide rate is the 5th highest in London, so that's the comparator on public health fingertips. So we were able, as Lisa said, to look at a segment of 58 suicides in the borough. And what's interesting is that 2/3 had an underlying mental health or drug and alcohol issue. We are imminently about to publish the suicide work, so it'll all be on our website so that you can scrutinize it. And it summarizes really well all the data that we have. I think it's about certain risk factors that say we have higher levels of in this borough. So rates of unemployment and other sort of things that make it harder for people. But there's a whole bunch of recommendations working across the Mental Health Trust with Children's Services and working with emergency services as well. And Helen Mangan has been really instrumental in the, it's called the Hammersmith and Fulham Care Partnership, the mental health campaign group. So Helen's been hugely supportive on our task and finish group, because any kind of prevention work in suicide isn't just one agency, it's all of us. So it's education for kids in schools, it's blue light services, it's how we work with and support our most vulnerable people. And then it's also sort of taking a universal approach so that people know where to turn to in a crisis, and also just any kind of healthcare professional having the right skills if people come to them or if they suspect suicidality. We've also started some very crunchy pieces of work. One is a peer review with the local government association, and one is an audit of everyone who self-harms and comes to accident and emergency. So it's a huge undertaking. It's about 23 different recommendations. And as I say, it should be imminently published.
Could I just have a follow-up, please? Just on that basis, could you please provide a copy of that for all of the panel members?
Sure.
Because it's a significant area that we don't hear enough about. It's swept under the carpet. And I'm not apportioning blame anywhere, but it's something that is really very, very important. And we need to actually have more understanding about what is going on and what we're doing in order to help prevent this.
Thank you.
Yeah, if I can just clarify.
Absolutely. And the link will be live. We'll only be able to share it when it's.
Nikki, if I
Thank
can-
you very much.
if I-
Thank you, Nikki. We've got Councillor Coleman.
Yeah, if I can just come in on that, just to clarify, Councillor Lloyd Harris, we know that this is a problem. We are taking steps to address the problem. So this is why the leader said that we need to set up a particular group across the council and also outside the council with expert people to look at the whole issue of suicide in the borough. This has been happening for some time now. This group's been set up. The work's been happening for some time. It's an extremely important piece of work. And I'm delighted, I have to say, to see that Listening Place is among the organisations that West London Trust is supporting. I went to visit them myself this Monday, and they're an extraordinary organisation. The fact that they're involved in strategy is also a good sign. But we are we will be publishing this. It will be full of data, but also full of what we're going to be doing as a council and as a health and care totality, if you want, in the borough, working together to try and, based on the understanding we're gaining, to try and reduce the rates of suicide. And we hope it'll be useful to other parts of London as well, where we know are looking at what we're doing. So it's not something that we're taking lightly, or that is.
Sorry if you thought that. I am obviously interested in this, as you know. So it's a fact of, I know you're doing things, but it's nice to know that it's still ongoing. It's not a finished work. So it wasn't a criticism at all.
So just for clarification, Nikki, so when will you be able to circulate the report with the committee, please?
We'll share the link once it's become in the public, once it's published on the JSNA website, Joint Strategic Needs Assessment.
Brilliant, thank you very much. I'm conscious of time. I would now like to invite Linda, please. You've got a question.
Yeah, just a request, please. So thanks for the additional information that you've sent out tonight, which is really important because those were the breach areas of the regulation. So there's really important. I just wondered for full transparency, if so these are the must-dos, could we see the rest of the action plan that covers the sort of 16 should-do areas as well? And that would be, I think, of interest to the panel. That would be helpful. Thank you.
Thank you, Linda, for that request. Councillor Coleman, I know you also want to.
Just a quick one, really is extremely quick. This is just to say a couple of little things. Congratulate Chris on his new job as the COO. Is that right? I believe. Congratulations. And also just to come back to what I was saying about the listening place, how pleased I am to see all the partnership working. I think it's tremendous. I'm looking down the names of all the people that you've been supporting, and I've worked with practically all of them, and I know them all. And I know what extraordinarily good work they do in the community. So it's tremendous to see that they're getting your support so they can help more people. So thank you for that.
No, thank you. And also just urge you to go into the embedded document, and it gives you a bit more detail of all the organisations. It's worth a read. Thanks.
Thank you, Helen. Joe?
Yeah, it was just really to build on that and just to say that the joy of the community grants programme that Helen's spoken about is that we're starting to see synergies across working with some of our more complex families. So Keith, you know, maybe where people are living with autism, they have mental health issues, they have children with disabilities. Some of the organisations are really stretching and evidencing what we can do if we all join up together. And the other thing I just mentioned is about community resilience and working in neighbourhoods. We've got mental health first aiders that are enabling us to more quickly get to residents who are struggling, and which links in with what Councillor Lloyd Harris was saying earlier. So I think that programme is really something to be proud of.
Thank you very much, Joe. Do you want to get back to Meryl, please?
Yes, I'll try. So first of all, apologies for the acronyms. In the spirit of sharing exactly what we're looking at in the trust, I had used exactly what we use in the trust, and I recognise for a public meeting that's not helpful. The referral rates, I was really sharing this, building upon the data that we'd shared earlier this year about what we perceived to be rising referral rates or a blip post-COVID. So the narrative that I would have added to this graph was one of reassurance, really, that we felt that blip was now stabilizing in a way that we hope will allow us to reach a steady state as the services themselves stabilize. And you make a very good point around the PCN data, which is of interest to us. And when we distributed the new resource that we received from Mint into our team structures, we tried to use weighted population anticipated demand in the way we calculated how that resource should be distributed, rather than historical patterns of access, with a view to recognizing that in some areas we might need to be more innovative, assertive, work with partners in order to address health inequalities. And it may yet be that we aren't doing enough. So we're very happy to continue to explore that with you. I was just going to mention on the suicide work, one other thing just to mention, I'm sure it's in Dr. Lang's report. Northwest, we're part of the Northwest London system, and across the 8 Northwest London boroughs, specific work has been commissioned through the third sector for suicide prevention and also postvention. So supporting the relatives of individuals who've been bereaved by suicide. Very happy to share the should actions. And really one final thing on the voluntary sector work, which I'm also really excited about and want to do more of, is I'm also really keen to find a mechanism for acknowledging that this is part of the investment that we're making in Mint. It is part of the Mint model, and these voluntary sector partners, you know, are working with us on that, and how we can capture in a sufficiently light touch way the value for money for the taxpayer of the investment that's being made in this.
Thank you very much, Dr. Hilton. Just to quickly summarize this agenda item, just a quick summary of the actions that have been agreed.
So just that last one is the key action which Linda's raised around the complete actions of the shoulds. And there was one further one earlier, which I can't access at the moment, which is on my laptop. So I'm very sorry about that. But it was to do with an exact figure of the number of staff. I can give you a bit more detail later on.
Thank you. It was the breakdown by the target is 28 days. Yeah.
Okay, colleagues, thank you very much.
Probably one further one as well around the EDI data.
I've got a waiting list.
Yeah.
Yeah.
If we're moving on, Chair, just to make a suggestion, which the committee is going to love me making, because we've taken a lot of time, I think more than we'd expected on this last bit. Perhaps we could extend the meeting by 10, 15 minutes if need be, just to make sure that we can give it proper scrutiny.
I'm very happy with that. Does the committee
apologize.
agree to extend the meeting 15 minutes? Okay. We extended by the guillotine. So the guillotine falls at 10 p.m. So it will be extended until quarter.
15 minutes.
15 minutes.
15 is enough?
Is 15, will 15 be enough? Okay, let's start with 15. Thank you very much. Thank you very much. Now, the second the follow-up item is the West London Trust mental health bed capacity, please. And you're also giving us.
I'll lead on this, and Helen will help, hopefully. I'll try to be brief in the preamble so that you can scrutinize. First of all, I wanted to commence by acknowledging that we are in an enhanced engagement period, and to apologize for any perception of a lack of engagement in Hammersmith and Fulham. That is entirely unintentional on our part, and we welcome the scrutiny from Hammersmith and Fulham members, residents, to the plans that we're putting in place. I hope that the committee understands, because the results of the proposal that we are putting forward will be that there will be no inpatient beds for adults in the borough of Ealing. There's been an inevitable focus on conversations and the impact on residents of Ealing, but we recognise that as our beds operate on a 3-borough footprint, it is of interest to the neighbouring boroughs, and I'm very happy to be here to speak to the item tonight. You will have read the paper, and I won't rehearse it, other than to say 2 or 3 points. The Trust, for as long as I've worked as a clinician in the Trust, and probably for longer, has operated our bed base on a 3-borough footprint. So the definition within the Trust of not being out of area has been that individuals, residents, have been admitted to one of the mental health units across 3 boroughs. Over time, our model of care has changed, and we do have a number of crisis alternatives, crisis teams supporting people at home. We have a recovery house in Ealing for residents of all 3 boroughs as an alternative to admission, and there are a range of other initiatives that have been put in place. When we entered the pandemic, we were struggling to staff the 2 wards in Ealing. We were struggling to provide safe infection prevention and control. There had also been criticism by the CQC describing the services as not fit for the delivery of modern healthcare in the 1831 premises. And on that basis, we suspended the 2 wards in Ealing. And the purpose of the enhanced engagement that we're now participating in, and the process, including the links in the document, takes you through the full case, and some of the background work that's happened to date, is to seek to make permanent those changes. I just want to make one absolute clear point from the trust perspective. This is about quality, and so there is, as a clinician, certainly I would not wish to be admitting inpatients to the facilities that we have in the Wolsey wing at Ealing Hospital. It is not about financial saving, and any financial savings are to be ring-fenced for reinvestment into the crisis mental health system. And the documents outline some of the interventions that we put in place. The 2 wards in Ealing together had a total of 31 beds. We have re-provided 18 of them in a ward that was available to us in Lakeside Mental Health Unit at West Middlesex Hospital, which leads to a net impact of a reduction of 13 beds. We have, however, invested money in additional services, including some in Hammersmith and Fulham and Hounslow, providing staffing to our Section 136 suites, which were previously not staffed, and other crisis-related care. So I'm happy to answer any questions. I'm sure there's lots of questions that people wish to ask.
Thank you, Christopher. I just want to make a comment just before we go to questions. We were quite disappointed because we heard the news from Ealing colleagues. So for us, it was, well, not great to hear about that route. Just to note that, please. It gives us a lot of confidence in the communication process. So just wanted to raise this. You've got a question?
I have a question.
Would you like me to answer them as we go along, or collate? Okay, so I'm happy to answer those questions. So I think the numbers question is a really important one. So prior to COVID, from a Hammersmith and Fulham resident perspective, about 25% of Hammersmith and Fulham residents requiring a mental health inpatient admission were admitted in either Ealing, in beds that we believe were not fit for purpose, or in the Lakeside Mental Health Unit. For the last 2 and a bit years since COVID, we've been operating a model of care without the benefit of the Ealing beds. So the 3 boroughs have been operating using the Charing Cross Mental Health Unit and the wards that we have at Lakeside Mental Health Unit. During this time, we remain one of the only mental health trusts in the country not to have had any use for unwarranted reasons of a bed out of our system. And you'll have seen there is press reports today about the use of mental health beds in the private sector, often in great distances. West London Trust remains one of the trusts that has not had to resort to that. And just to caveat before someone asks what the term unwarranted means, there are 2 circumstances in which we would admit patients in a way that we would describe as warranted, and that is when it's to access a service that we aren't commissioned to provide. So there is a female psychiatric intensive care unit, and we tend to work with neighbouring trusts to provide that because ours is a male unit. And the second is when we have to admit a member of staff, in which case we would arrange for them to be admitted in another organisation for their confidentiality and dignity. So I guess the assurance that I can give you to the best of my ability is that during the last 2.5 years, when demand has remained high, we have continued to remain within system for the beds that are required. And I guess to answer your second question, do we have a plan B? It's a very fair question, a very difficult one, because I suppose plan B, if the engagement period results in a request for us to reopen the Wolsey wing in Ealing, it would be an incredibly challenging thing for us to do, given the criticism that has been placed on the quality of the estate. Personally, I would really like us to be committing to building new inpatient mental health facilities in all 3 of our boroughs, but in the short term, that doesn't appear to be likely to be possible.
Thank you. I would. Oh, yes. Councillor Gorman.
Thanks very much. Thank you. It's reassuring about the some of the things that you told us about there, what you've been able to achieve in difficult times. Thank you for that. I've got a couple of questions. One area is to do with what's going to happen instead of 13 beds, and the other's about consultation. You don't mind. I mean, you say that the 13 beds in the report that you sent us. Well, you sent us one report, you sent us one document, and then you sent us a second document, and you sent me a letter. But we've looked. So I've been working on the basis initially of the Ealing consultation document, which was much more detailed than what you sent to this committee. But then you sent I think a Word version of the presentation that you sent to Ealing just a couple of days ago. So I appreciate you did that, although we'd happily have had it 2 years ago whenever Ealing got it. But anyway, the funding for the 13 beds, you're saying it will remain ring fenced and reinvested in the range of acute crisis and community-based services across the 3 boroughs. But the CQC, which we've talked a lot about, has judged that your community-based mental health service requires improvement in important areas. It's inadequate for adults of working age when it comes to safety. And so it's sort of worrying that you're going to be closing the beds, moving to community services. And what I'd like to understand, and perhaps we can take that and then come back to questions about consultation, Chair. So what evidence is there that you actually are going to improve what's happening in the community, what you might call the clinical wraparound, in lieu of the beds? Because at the moment, we lost the beds, community services aren't good enough. A little bit worrying.
Happy to take that point. So I think there are 2. So within my portfolio, we have 2 sets of community services. We have community services that we've been discussing for the majority of the meeting this evening, which are effectively the planned care services that we have within the division. In addition, we have a whole range of other community-based crisis services, which are the mental health version of a kind of non-elective pathway. That includes our home treatment teams, our crisis teams, our crisis alternatives, including the work we're doing with Mind and the safe spaces. It includes our health-based places of safety, the Section 136 suites. It includes the Recovery House, which is run for us by the Richmond Fellowship, based in a residential facility in Ealing. So those services are the ones that we are seeking to ring fence and bolster with the investment that was previously used for inpatient crisis mental health care. Just to be clear on the numbers, the money that we're describing originally was 31 beds, and we've spent a fair chunk of that re-providing 18 of them, and that was estates driven. And the rest is absolutely intended to be ring-fenced for, and I think there's a list in some of the documents, the staffing for the 136 suites to make sure that we're able to respond more assertively to individuals brought in by the police, the we've ring fenced some money for step down provision in sort of supported living environments. And there's also some money set aside, and I was interested in the conversation when Professor Orchard was here for transport, because we recognise that the crossing borough boundaries is of concern if people are, whilst we consider them to be in area, they themselves may not. So that's the ring fencing.
All right.
Okay.
Okay.
Coleman, you've got questions on consultation.
Yeah, I'm going to, in the interest of time, I'll move on to those, but thank you for that, Chris. As the chair mentioned, we're a bit peeved. We're a bit peeved. It affects our residents. We found out about this from Ealing. Do you intend to consult properly with the residents in Hammersmith and Fulham?
So I wanted to start up front. There is no intentional decision not to communicate with you or to communicate with residents in Hammersmith and Fulham. The advice we've received from NHS England in the London region was that the approach we should take is one of enhanced engagement, which is identical to public consultation, and we are open to that enhanced engagement period now. I appreciate you received a letter from us this week belatedly, and I apologise for the delay in that. And it was discussed at the Joint Health Overview and Scrutiny Committee, the approach that we were intending to take. The engagement period is open, and I believe we've also, I hope Jim will not tell me that I'm incorrect, written to HAPSON about the period.
What's the difference between enhanced engagement? Forgive me, just because we're short of time. What's the difference between enhanced engagement, which you say you've been told to do, and consultation?
In practice, they are identical in the approaches that we are taking. The advice from NHS England was a technical one related to the assessed scale and impact of the change.
Yeah, because according to the statutory guidelines, where substantial development or variation changes are proposed, you are meant to consult the local authorities on how they think you should go about consulting. And I give you chapter and verse on this, but when service changes are deemed substantial, and the definition of substantial is something that you agree in discussion with the local authority, then you have to run a quote full public consultation. We weren't approached. We consider these substantial changes. We'd have had that discussion with you. We weren't approached to have that discussion, nor was Ealing. It was informed that this was going to be an enhanced engagement. I think we have concerns about whether the process you followed is appropriate within the and whether if you've had advice from NHS England or NHS London region, obviously we'd be interested in seeing that, but we have questions about whether the process that's been followed is appropriate, given that this is a substantial, in our view, a substantial development or variation to an existing service. And given that, we'd like to understand better what opportunity there is for a proper consultation now with the residents of the borough, or if you intend to continue just down the path of enhanced engagement with 12 weeks to comment.
So certainly it was our intention to continue with that enhanced engagement period, seeking as many opportunities as possible for residents of all three boroughs, including Hammersmith and Fulham, particularly for the purposes of this evening, to comment. If there is an opportunity to have further conversations with the local authority, and I recognise that this is trying to repair failings earlier in the process, we would welcome those further conversations to understand how we can take this forward in a way that is deemed to be satisfactory to the local authority.
So that would, so we have the opportunity to talk to you about how we think, and it may be that having discussions with you and looking in more detail about what you're talking about, and through that we would say fine, but we have the opportunity potentially through conversations with you to change the plan that you have to enhance it, to enhance the enhanced consultation to the level of engagement. Sorry, all these NHS words, anything in the NHS to avoid the word consultation. It seems to me, having been dealing with this now several years, anything, despite the statutory guidelines that the NHS has itself in 2018, set out in 2018, we may think that it's appropriate to expand the engagement of the consultation that you've done. And I hope that in the discussions we have with you now, that opportunity, that possibility, that option will be there.
I would very much welcome the conversation about anything we can do to to take forward the full input of the local authority, local residents into the plans that we have. And certainly there are 2 or 3 things that I think I hope are in train that will support us to do that. One was a meeting of the 3 chairs of scrutiny committees, which I understand Councillor Crawford from Ealing had agreed to coordinate, but also I would very happily host anyone at the Wolsey wing in Ealing to understand exactly what the services we're trying to describe are. But absolutely, we'd be happy to do anything that the council feels is appropriate to enable us to ensure that we've sought the opinions of local residents.
And would that, thank you, and just the last bit of that, that's very helpful. Thank you. I appreciate your positive response. But would the last bit of that be to understand a little bit better about what will be happening? And I appreciate what you've already said about community services, but about what will be happening to improve community. So I know you're making between crisis services and continuous services, or whatever the right phrase is, but to reassure the concerns that we have in that part, as part of the consultation and as part of the outcomes that you might be aiming to achieve?
Of course, I think that yes is the short answer to that. I think we need to look at the interdependencies between the different bits of the out of hospital offer, the practicalities of the estate in which we're working, and certainly from my perspective as the director of this, I would be keen not to be in a position where I had to reopen facilities that aren't felt as fit for purpose, but there's no question about us wanting to have your input into a satisfactory resolution for local residents.
Thank you.
Councillor Coleman, I'm keen to move to I know you've got one question.
I think really it's following on from what Councillor Coleman said. I think, Chris, you've actually said far, far more in response to questions this evening from Councillor Coleman than actually exists in the paper. I've got a substantially different understanding now of what the problem is, what the problems might be with some of the solutions, temporary or otherwise, you've got. And it doesn't seem to me that this document as the basis for engagement, enhanced engagement or consultation is adequate. And I think the case has really been made that if you go forward for a full closure rather than a temporary closure of beds, you need to come back with a far more elaborate paper so we can actually make a judgment, not for sticking plaster, but for the longer period of time.
I'm very happy to continue the conversations with the committee and with Hafson. Can I draw your attention, please, Jim, to there's a link in the paper, and I didn't provide the full suite of documents to the committee today, but linked explicitly to them, which includes the work to date, the case for change, video materials showing some of the services that we're seeking to close, and some of the equality health impact assessments, both for staff and local people. So please do. Can I draw the committee's attention to that link, which is buried within my admittedly summary report?
I just want to go back to the point of the enhanced consultation. Is there room for you going back to the London region to express our concern from Hammersmith and Fulham, to see if an extension can be given to the whole process? Because I know from your report that you've got a timescale and you're intending to produce a report in January 2023. We're now in November. We clearly want a meaningful consultation with our residents and with other stakeholders. And I personally feel that doing it in less than 2 months won't be enough.
So to answer your question, Councillor Perez, I think there is scope to extend the period to the satisfaction of the neighbouring authorities. I think that, if I may, could I suggest that we continue the conversation about the next steps that might be acceptable to yourself and to other members in some of the meetings that have been proposed, and I'd be very happy to confirm that it's possible to extend the engagement period.
Thank you. I know that Lisa has got her hand up.
Okay, Christopher, thanks for that. And I won't repeat the what's been said about consultation, but I have to say and that if we hadn't heard about it from a colleague in Ealing, we wouldn't have known about this. So I absolutely think it warrants, given the loss of 13 beds, warrants full consultation. So I just wanted to echo what's been said. You've kept saying that you'll share with us the poor state of the beds that you're seeking, that you've had to close. I don't really think the argument is about having substandard facilities, certainly not for me, and I don't want to speak on behalf of the committee, but I shouldn't imagine any other members would want people staying in substandard accommodation. But A plus B doesn't equal C, and I think it feels like substandard accommodation, and then appreciate you've created some additional beds in Hounslow, but that doesn't mean to say that makes up for a loss of substandard beds isn't good enough, but that doesn't mean that then we should be closing, we shouldn't be creating new beds. And I think that there's a number of things that we'd want to pick up in a full consultation. For example, step down and supported living beds, and some of the ones that you've described earlier are not the same as acute beds. People who go into acute beds are usually seriously ill and needing a very high level of, and not that I need to tell yourselves, very high level of intervention. I'm not arguing that wards are the place to do it, but what I am arguing is that they need usually a specialist bed. And given the state of community services generally, I mean nationally, not just locally, I don't yet think there's sufficient clinical support to be able to make up for those loss of beds. You've mentioned about travel time to Hounslow for residents and carers. That would be an issue. That's why it's important for consultation, because I think carers, if they're visiting their loved ones with a long-term condition, find travel really tricky. Hounslows not so easy to get to, and indeed parts of Ealing, are quite a way away. So I think all in all, I do have to say that I support that we need a full consultation with residents and their carers in Hammersmith and Fulham, and I think 13 beds is quite a significant amount of beds in the round, given that there's been a huge loss of beds in London over the last, I don't know, 15, 20 years. So it's a concern, Christopher, for me.
Thank you, Lisa. Colleagues, I'm keen to close this item because I note the time, and I note members of the PAC have been very, very patient this evening, which is appreciated. Is there one last point that you wish to?
I just wanted to thank the committee for their feedback to the paper. I wanted to commit to the further conversations with the committee chair and the Health and Wellbeing Board chair and other members of the committee. I just want to acknowledge that the beds have been suspended for 2.5 years. So we have some evidence based on the performance of the services over the last 2 years, and this is about moving to making permanent something that has been temporarily in place for some time, but recognize the concerns of the committee and happy to have further conversations.
Thank you very much, Christopher. It's appreciated, and thank you very much, Helen. We've got, I think, 90 seconds left to approve the minutes. Can I ask members of the committee if they are happy to know the previous minutes held on the 12th of July? To know other outstanding actions as well. Thank you very much. And finally, the work program. So, Bathsheba, can we do this?
Council happy to do the work program offline.
Okay.
If everyone's happy with that.
Yes. Okay.
We have got a few items mapped out for January and March, so I can circulate those.
Including one item about the impact of long COVID.
Yeah, long COVID.
Well, thank you so much. Can I reiterate my thanks to all of you for your patience this evening and all your contributions and questions and helping us scrutinize. Thank you.